Good morning, everyone, and welcome to the WAGE annual meeting. This has been delayed for the reasons that I think are obvious to all of us. We originally wanted to have the spring meeting in March, which was on the eve of lockdown as it happened at the time, and our autumn meeting consequently also had to be delayed. But we've got a fantastic program for you today and hope that you all enjoy it. It's very varied and we've got excellent speakers locally and nationally. So the first session is going to be a quiz that is going to be presented by my good friend and colleague, Dr. Jamie Barber. Jamie is someone who has established his expertise in this area, in the area of colonoscopy, screening, polyp detection, characterization, and therapy for early lesions. And I can't think of anyone better who'd be able to teach us the tips and tricks that are required. And I'm sure we've got a lot to learn from it. So thanks a lot and take it away, Jamie.
Okay. Okay, so welcome. Thanks for having me. My name's Jamie Barber. I'm a gastroenterologist in Gateshead, the northeast of England, and I was lucky enough to spend some time down with Professor Dolwini down in Cardiff, and I've worked with him for a while in the team down there. And I'm going to do a little quiz over the next 20 or so minutes, and what I'm going to do is hopefully make it relevant to all endoscopists that are watching, and not just the experts, but also the people who are in training and people who are doing endoscopy work. Hopefully, and who are undertaking therapy. And I'm also going to give some tips and tricks to hopefully avoid some complications. So hopefully you'll find it useful. And just more specifically, just because I'm keen on training, and just so that you all know what you're going to get out of this next 20-25 minutes. Hopefully by the end of it, you're going to recognize the importance of optimal assessment, because I think that's a really crucial aspect. Ancillary maneuvers are actually really important, and it's not just about looking at something and giving your best guess, but actually doing things to it to make it much more clearer and easier. Stalk polyps seem to be treated fairly differently, and hopefully I'll give you an idea of the way I and the Cardiff team treat these types of things. And then lastly, to understand the place of ESD in the management of complex polyps. So it is a quiz. It's recorded. I was going to do it live, but it's recorded. So the first case is a polyp in the rectum, and I'd like you to have a look at that polyp. It's a pretty straightforward polyp, and that's why I chose it. We've only got two pictures, this one and the post-resection picture. It's clearly not ideal, but I think you'd all agree that it looks fairly benign and relatively harmless. The pit pattern is 4, maybe 3S, and its morphology of a 1SP lesion is probably about 8 millimeters. And there's the post-resection. So he actually had a focus of cancer within that. There was no vessel space invasion, no port differentiation. CT and MRI was okay. What should have been done prior to the endoscopic resection, and how could the resection been improved? Well, essentially, you must assess the lesion, and I don't think that this lesion was assessed as best as it could have been. And the focus of assessment is looking for any increased risks of malignancy, and that would include pit pattern 5, nice MBI pattern 3, any subtle signs of cancer or invasion, such as fold convergence, and then any heterogeneity of pit pattern or morphology. That all increases the risk, and it makes you step back and think, hang on a second, is this really what I need to, would this be okay to take off with my skill levels? And then the documentation is really important with a retroverted view as well. And how could it have been improved? Well, certainly injection into the base and using a snare down with the normal tissue is standard practice and good practice. And certainly in the rectum, if there's any suspicion of malignancy, then you should certainly be considering en bloc resection. And this chap actually went on not to have any cancer, but had an anterior resection. And this is the sort of thing that I've been put on the earth to try and avoid. And you know, he still looks back on that time with difficulty. So the next case is a sigmoid lesion, and these are the two photos that were given to me prior to EMR. And this was described as a 60 millimeter subpedunculated polyp with pit pattern 4. And there was only 2 photos. So the question is, on this lesion, what maneuvers could have been employed to enhance the assessment of this lesion? And you really can't tell from these photos what this lesion is, whether it's a large sessile lesion or whether it's pedunculated, whether there's any sign of any invasive areas. So the answer to this question is that you should move the patient, okay? And that's a really important take-home message. And that great big pedicle makes a complete difference to the removal of this polyp. So moving the patient, and this is a dye spray catheter that you see on the right hand side, and that is really helpful in just mobilizing the head of the polyp to see where the base of it is attached to, and that's a really important lesson. So dye spray catheter to mobilize the stalk and position change. And the next question is, what about pedunculated lesions? How do you manage them? And lots of people do different things, but I have some recommendations. Do you inject pre snaring? Do you put clips on? Do you use the poly loop? What are the diathermy settings? And do you use a clip following the therapy? Well, there's a stalk that I did on Monday, and what I would recommend, or at least what I would suggest, is injection into the stalk. And the reason I say that is to put some adrenaline in that stalk to vasoconstrict the vessel in the center of that, because that's the danger here. And that's that done there. And this is a similar large pedunculated polyp. And then you've got a long stalk that you can put the snare around wherever you want, and you can do it low down, or you can do it high up, or in the middle, depending on the cancer risk and the bleed risk. Okay, so essentially I would inject into the stalk. I wouldn't bother with clipping. It doesn't really do that much, and I'm not sure how reliable it is. Polyloop also has a problem, because if you're narrowing the stalk, that's where the diathermy is going to be narrowed as well, and you can get kind of heat injury just where the polyloop is. And diathermy settings, coagulation. Don't use endocut on stalks. You need to slow cook that through so you don't get any bleeding. And using your assistant to cut through, or you can hold the snare yourself, but it's got to be slow, and that takes a little bit of subtlety in talking to the assistant. And what I tend to do is I use a coag grasper if I see any big vessels, and coag the vessel straight on, plus or minus a clip. And there's some evidence that using a clip following a therapy of a pedunculated polyp greater than 15 to 20 mils reduces the rebleed rate. So what about this lesion? It's transverse colon, and you see the lesion on the right. I've got another picture here. That's a bit of dye spray. And the question is, what's the morphology of this lesion? And if you were to attempt resection of this lesion, would the oral or the anal side be most challenging? So just looking at that lesion again, you can see it's quite bulky on the left-hand side, but then it's relatively smooth with the dye spray on it, and it's quite flat going into that right-hand picture on the top right-hand corner. So so I would call that LSTNG, and there's quite a significant risk of cancer. 88% don't have cancer if we're going strictly by their figures. 12% do, more approximately, according to studies that I'll show you at the end. But the oral side is going to be tricky there, because you're going to remove, if you do attempt it, you're going to remove those nodules first. But then as it goes round the bend, that's going to be tricky. So you've got to be careful about that. Here's a mid-rectal lesion. What do we think of that? It's near focus and MBI. It's quite a flat lesion. What's the morphology? What's the pit pattern? How would you describe it covering the fold, and how should this be removed on block or piecemeal? So if you look closely, you can see that on the right hand picture there's some pit pattern 4, but then in the center it's different pit pattern, and you really need a zoom scope to identify pit pattern 5, because it might be pit pattern 3S, quite small and dotty like. But this is a bit more sort of brain pattern on the edge here. So and it's quite a flat lesion, and you could suggest that that's a 2C lesion, whether it's depressed in the center. And if it's 2C, obviously you'd be worried about cancer there. So I would say that it's an LSTG on the edges and an LSTNG because it's quite smooth in the center. And I think that the pit pattern is on the edges about 4, but it might be 5 or 3S in the center. I describe it as clamshelled, and I would recommend that you remove it en bloc because of the cancer risk in that. And that's it, removed en bloc and pinned out, and it was actually benign with high-grade dysplasia, but it was removed en bloc, so you don't need to actually come back to it. Now with ESD, you often think many polyps or all polyps can be potentially removed, and this is a low rectal lesion. It's about 2 centimeters in size, maybe 18 mils compared to the scope, and there's the pit pattern in the center of that, and the question is, well, the biopsy of the central area of the lesion showed high-grade dysplasia, and the question is, would you offer endoscopic resection? So they biopsied the center of that on the right-hand side, and it's just shown high-grade dysplasia. So do you believe the biopsy, or do you believe what you see in front of you? And I think most people would be quite concerned with that sort of pit pattern in there. You can see some dots in there. You can see some enlarged vessels. That's the dark browny black kind of things. Some black blobs. You've certainly lost that pit pattern that you got on the edge in the center. It's irregular. Plus the morphology is very concerning, and the answer is no, you wouldn't offer endoscopic resection because of likely invasive malignancy, and it's going to be T2 or more by the nature of the button type morphology, and it did turn out to be a T3 cancer. And this is a very typical lesion that you see on the left hand side. It's got a little bit of stool. It's very subtle. If you could go past that really easily, but once you wash it, it's kind of got that glistening appearance, and you can see that the normal colon with the normal vascular pattern is disrupted. You don't see the white anymore. It's all sort of glistening and a little bit sparkly. The question is, what sort of lesion is this? And this is, I'm sure you know, it's a serrated lesion. And it's absolutely vital that you wash the colon on withdrawal, and any bit of stool that you see, you clean. Now, this is a mid-rectal lesion, and what do we make of that, I wonder? What's the morphology? Is there anything that gives cause for concern prior to endoscopic resection? And would you try and EMR it or arrange for an ESD? Well, the key to this picture is that the fold convergence, and there's folds going into this lesion that make it not look what you don't normally expect. Polyps sit on the mucosa. They don't go below the mucosa unless there's invasion, and they follow the contour of the folds. They don't disrupt the contour of the folds, and this is disrupting and actually pulling in the folds. So either this is an invasive cancer, or it's a polyp that's had treatment therapy before and had some scarring, and it's actually it's an LSTG with scarring, and there's fold convergence and scarring indicating previous attempts and likely failure of lifting, and you've got to you can't really EMR those things. You've got to ESD that sort of thing, and it's and it came off quite nicely. This is a big rectal lesion, and it's a, well, what do you make of it? And this is the same lesion after treatment, after therapy, 12 months later. So what's happened, and how do you treat that? Well, there's the normal on the right hand side. You can see the normal bowel. The right hand picture, to the left of this picture, you can see the normal bowel. To the right of the picture, you can see some recurrence, and that's quite extensive recurrence. and that's and you can, on the left side picture, you can see some scarring as well, following sort of extensive EMR. So this is a case of scarring, and this is what you need ESD for. And you can cut through that scarring with the right skill level, and you can end up sort of getting the whole thing off, but it's pretty difficult. And coming towards the end, we've got a cecal lesion, and for people doing diagnostic work, the question is here, what two things do you need to establish with these types of lesions? And you can see this is the cecum. It's not all that clear, and there's a little bit of stool there. On the left hand side of the picture is the ileocecal valve, and I'm sure you all know that you've got to find out whether the TI is involved and is it clear of the appendix. And you really need to do a picture of the appendix and go into the TI and see if there's any invasion into the ileum. Usually there isn't, but sometimes there is, and it just helps the job along if you can take pictures or a video of you going into the TI, and then we can either refer for a right hemi or offer endoscopic therapy. Okay, and lastly, I'm just going to show this. It's really useful. LSTG granular lesions are usually flat and have actually got quite a very low risk of malignancy. So these can be offered piecemeal resection perfectly reasonably anywhere in the bowel. And you've got a 1 in 100 chance of cancer. It's very low risk, and approximately it's even lower. But when you get to LSTNGs down on the right hand corner, that's coming up to 20% risk of cancer. And you really need to be offering on block resection if you can, particularly in the rectum, but a careful discussion about what you do to remove these sort of things with the patient before you actually remove them. And that's why an MDT is so important with these complex lesions. Is you can offer the patient everything that is available, and it's up to the patient to decide, not the endoscopist. That's what I would say. And that is it. So I hope you've enjoyed it. I hope you've learned something, and hopefully I've achieved my objectives of making it relevant and starting off in a pleasant fashion.
Thank you very much for inviting me to speak at the annual and now virtual WAGE meeting. I'm grateful to Sunil and the organisers for inviting me to talk about improving your polyp detection rate, technical tricks and tips. This talk is normally improving your...
Okay, so we're live in 3, 2, 1.
Okay, thanks very much for that, Jamie. That was a really super presentation with some really interesting cases. We've got some questions coming in, and the first one's about, again, saying nice cases, thanks a lot. Do you have a local endotherapy to discuss optimal management? And if you do you ask for video clips because they seem to be more useful than still images? That's from John Green.
Yeah, we do have an endotherapy group. We have a regional MDT that we have every fortnight. We try and get clips, but we haven't quite set that up. That is quite challenging. And video clips are really useful, and they do bring an additional information about the polyp, and as much information you can get is the best thing you can do. So we occasionally have clips. We aren't quite as organised as Cardiff in the fact that they insist on video of all the lesions. You have to be quite careful that you don't end up with poor quality videos. It's about, and the same goes for the pictures. You can take pictures, but they can be quite poor quality. So attention to detail, everything in focus, different angles, different closeness and far away, those are important. They give you a lot of information. Videos are quite good, but they can also be fairly poor quality as well. So it's a combination of photos and videos and an assessment at the time. But we do have endotherapy meetings every 2 weeks. So you're on mute.
Sorry, Jamie. That was good. I was just going to ask you, what's your opinion of trial lifts? Because a lot of people seem to think that that's fine. I'm always a bit concerned about if you've assessed a polyp as being potentially worrying, whether you should or you shouldn't lift it. What do you feel?
I think you just like photos and videos, you can get different quality of lifting skills, and you can get different quality of assessment of pit pattern. So just the other day, we have a lesion that was described as pit pattern 5, but they didn't take a photo of pit pattern 5. So I'm always a bit dubious. If you see pit pattern 5, that's fine. Take a really good photo and show us what you mean by pit pattern 5. Trial lifts are similar in the sense that it can be quite tricky to get the fluid into the right place to get that lift. And so just because it doesn't lift doesn't mean to say that it won't lift. So I generally would avoid or encourage people to avoid trying to lift it, because it just if you're going to take it off, that's fine. But if you think that you probably won't be able to take it off, then don't try and put a lift in to see if it adds any information, because it can compromise the resection later, and it's not necessarily that useful for me.
Yeah, I agree. I think that's the actual tricky bit, that it does cause some mucosal fibrosis later, doesn't it?
Can do.
That is a difficult one. I was actually going to ask that as a follow-on, that I guess people who lift it have got to be prepared to either take it off completely and then tattoo the area, or not attempt it, because that partial resection is a house of horrors for us usually, isn't it?
Definitely.
Any tips on the cecal and appendix type lesions, Jamie? What do you think? I mean, some people would suggest that going in with a cap, if you know there's a lesion there, might be helpful. What do you feel?
Cap is good for big lesions to help you see the base and to get the injection into the right place and get the snare in the right place. You need to be using it quite regularly rather than just occasionally. So I think there's a slight danger that you're using something they're not used to. In terms of injection into the cecum, you can struggle to get the lift. So very often the scope approaches the cecum in a perpendicular fashion. So the cecum's at the bottom and the scope is going directly towards it, whereas most of the rest of the colon, you're at a tangential angle when you're arriving at the colon. So, and I think that's part of the problem when you inject into the mucosa when it's straight on. The gap between the mucosa and the muscle is squashed and quite small, so it's quite difficult to get that fluid into that submucosal space. So trying to go at an angle can help. get a little bit of a lift, and that sort of. The other thing is when you push the needle in, you push it in under the injection fluid, and then you lift it up so that you're moving the tip of the needle through those planes of tissue until you get that little blowing up of the right part of the tissue. You can get blebbing and you can get nothing when the injection is going straight through, but just try different places, try different angles, and you should be able to get it. The appendix is quite tricky, and you have to make sure that you can remove the whole thing and you can get to it. If it's tunneling into the appendix, you shouldn't start.
Very useful tips, Jamie. I agree. We've got a question about what about underwater photos, because there seems to be a vogue at the moment for underwater colonoscopy. And even though the WASH trial didn't suggest it had much improvement in patient comfort, what's your opinion of taking underwater photos in this situation?
Well, I don't think I've ever taken an underwater photo. I think, as Noriko Suzuki says, there is some slight magnification with water. So that might help a little bit. So I tend to wash and take really good photos as best as I can without the use of water, to be honest. So I just don't do it.
Yeah, I must admit that's my practice as well, though undoubtedly water does magnify it and gives you nice images. Hopefully, if people have washed the lesion really well and outlined the pattern well, then that should be clear enough without necessarily needing water. And these days, particularly if you've got a nice high definition scope or if you've got near focus, that should be good as well.
Yeah.
So there's another question here. What are your tips for trainees who'd like to pursue advanced endoscopy, from Lavanya?
Well, I think training, I'm really interested in training. We do a lot of courses up in Gateshead, and we do advanced therapeutic courses as well. And it is very difficult, and you have to have a trainer that is prepared to see you through a period of training where you are getting an enhanced training for therapy. So I think fellowships are a way to do that, and there was a BSG email recently saying put all your fellowships on the BSG website, and I think that'll be a useful way of trainees finding their place for sort of extra training. I think it's incredibly difficult for a trainee, particularly if you're going to reduce the length of training down to 4 years, which is now the new model, to get up and running in diagnostic endoscopy as well as therapy. So I think it's practically extremely difficult. If we in the future introduce much more intensive endoscopy training over 1 year period, and I'm a big advocate of that, then once you're up and trained diagnostically, you can go to centres where they do more therapy, and you can attach yourself to the trainer that does some therapy. So I think things are changing, but in one way it's getting more difficult because the training is shorter over 4 years, and possibly in the future there's hope that we're going to be a bit more intensive. Okay,
very quick question, brief answer, please. There's a question about, are we in danger of making the DGH endoscopist scared to remove a polyp? And are you finding an increase in referrals in the local regional complex polyp MDTs because endoscopists are worried about tackling difficult polyps? So brief answer, please.
Yep. I am from a DGH, and we've developed a sort of a regional team meeting. So I think that there's a drive to improve the quality of therapy, and if that means that people who don't do that much therapy stop doing it, then I don't have a problem with that. If there's lots of lesions available, and you know, I'm all for training up people in DGHs to remove lesions that they feel comfortable with.
That's brilliant, and I'd really second that, because some of the big centres around the UK essentially are not big teaching hospitals, but DGHs where people have had the drive to improve the quality of their therapy. That's been a fantastic session, Jamie. Thanks ever so much. I'm sure we've had lots of tips from it. Great interaction there. So thanks very much.
Thanks.
We'll move on to the next bit. Thank you.
Thank you for inviting me today to join your virtual conference. As this meeting is now being recorded, I will need to read out the following disclaimer. This promotional presentation is intended for UK healthcare professionals only and has been prepared and approved for use by Intercept Pharma UK and Ireland Limited. No part of this presentation may be reproduced, distributed, or transmitted in any form or by any means, including recording or other electronic methods, without the prior written permission of Intercept. I would like to talk to you today about Acalava, which is the only recommended and licensed second-line treatment for PBC. Employs a phase 3 clinical trial significantly more patients on the URSO and add-on Acalava arm versus the placebo URSO arm, met the primary composite endpoint, which was patients on Acalava plus URSO needed to achieve the ALP of under 1.67, the upper limit of normal, as per the BSG guidelines, and have a 15% ALP reduction from baseline, and was also then making sure that the total bilirubin was under the upper limit of normal. This trial then went on to an open label extension phase, which went up to 6 years of treatment with obeticholic acid. And as you can see from the results, in the first year, the titration arm of obeticholic acid 5 to 10 milligrams, 46% of the patients met the composite endpoint. After that year, there was 3 months where all patients received a 5 milligram dose, and then there was a dose adjustment in the open label phase. Pruritus and fatigue were the most common adverse events in the Acalava treatment arm. And so on to the results of the long-term efficacy and safety open label extension of the phase 3 trial. So 82% of patients completed 4 years of Acalava, 60% of patients completed 5 years of obeticholic acid in the long-term extension study. In the final 6th year, it was 52 patients had received Acalava in the double-blind phase trial. So following the administrative shutdown of the study, because the primary endpoint was met and the durability of response was demonstrated, 76% of patients completed the protocol as specified. What the long-term extension study demonstrated was that after 48 to 72 months of obeticholic acid treatment, 50 to 56% of patients met the primary endpoint, demonstrating that reductions in ALP were sustained throughout the 6 years of Acalava treatment, and that the total bilirubin remained stable and within the normal range for most patients for treatment duration. So to adverse events, they were generally mild to moderate. Most common adverse event was pruritus. Again, events were generally mild to moderate. 69 patients experienced a serious TEAE, but the summary includes any event that had occurred in above 10% of patients in the total Ocaliva group. And 2 deaths occurred during the Ocaliva long-term extension. Both were assessed as unrelated to Ocaliva. So in summary, 6 years of treatment with Ocaliva resulted in sustained improvement or stabilization in markers of cholestasis, inflammation, and fibrosis. Adverse events were consistent with the established safety profile of Ocaliva in patients. Safety observations during the long-term treatment out to 6 years were observed. Overall, there was a low rate of liver-related morbidity. If you have any further questions, please don't hesitate to contact me. Your course coordinator has all my details. Thank you for your time.
one.
Good morning, everyone. You all know Joe, and we've had a fantastic first session, which was the lower GI recognition quiz with a good discussion. This is the endoscopy, surgery and pathology session, and our first speaker is going to be James East. James says, good morning, everyone. James is consultant gastroenterologist in Oxford and from the translational gastroenterology unit, which was the lower GI recognition quiz with a good discussion. This is the endoscopy. And we are really looking forward to his talk on improving your polyp detection rate. James is a recognized expert in this area and has written a number of publications and guidelines, and I can't think of anyone better to synthesize the evidence for us. So thank you, James.
Thank you very much for inviting me to speak at the annual and now virtual WAGE meeting. I'm grateful to Sunil and the organisers for inviting me to talk about improving your polyp detection rate, technical tricks and tips. This talk is normally improving your adenoma detection rate, technical tricks and tips. And I wonder whether Sunil had made a mistake when he was writing the invite. But in fact, the ground has shifted underneath us in the last year or so. And this is the new polyp follow-up guidance from led by Matt Rutter from the BSG. And it now defines high-risk findings slightly differently. In particular, they talk about pre-malignant polyps. And when they define pre-malignant polyps, you'll see right at the front there, it includes serrated polyps, excluding diminutive rectal hypoplastic lesions, and adenomatous polyps. So polyps is very much now the name of the game, rather than being too didactic about the pathology as to whether things are neoplastic and require surveillance or not. So those are disclosures. So in terms of what we're trying to think about today, I am actually going to split it a little bit here into adenoma detection, and I'm going to talk about the basics because I believe they matter in terms of really driving successful cancer prevention. I'm going to say a brief word then on advanced imaging and devices for adenoma detection, and then we're going to look at serrated polyps and look at imaging and devices. And finally, I'm going to talk about artificial intelligence, which is perhaps our most recent trick. And I think, as many do, that this is going to be a bit of a game changer for polyp detection. So why are we interested in adenoma detection? Well, we know we've got a problem with cancer occurring after colonoscopy, the post-colonoscopy colorectal cancer rate, and this runs from about 2006 to 2013. The proportion of cancers that occur after apparently a clear colonoscopy has gone down from about 9% to about 7%, but still a very striking level. And we can see that if your performance is optimized, but by optimized here, we're using a surrogate of bowel cancer screening colonoscopists, we can potentially drive that post-colonoscopy colorectal cancer rate down lower, maybe somewhere between 3 and 4%. And in terms of how we think that cancers occur after colonoscopy, we think that about half of them are due to missed lesions. So fundamentally, if we're not detecting the lesions, we can't resect them and we can't prevent them developing into colorectal cancers. So in terms of what we might think about for the talk today, we are aware from the Corley et al. Data, this is now very well known, that there is a strong correlation between adenoma detection rate, not yet polyp detection rate, but adenoma detection rate, and the risk of post-colonoscopy colorectal cancer, and in fact here, death from post-colonoscopy colorectal cancer. So many of you in the audience will be maybe in quintile 4 here, and thinking, how can I go to quintile 5? Essentially, we're saying, can you go from good to great? And I would ask you, rather than thinking about this small improvement in the risk of post-colonoscopy colorectal cancer death, this talk is not really for you, or at least not for you personally. This is perhaps a talk for those lower performers in your unit who you can help to be a better performer. Because if we're going to prevent post-colonoscopy colorectal cancer, this is what we need to achieve. We need to get the low performers, many of whom may not be engaged and not have come here, they're not very focused on their endoscopy, to go from really quite poor to moderately good. And in fact, we will prevent a lot more cancer by achieving this than by optimizing people who are already very good. There remains the question that all of this effort, there's obviously an association between adenoma detection and post-colonoscopy colorectal cancer, but that's not the same as causation. And so I was really pleased to see this data from Mikhail Kaminsky, who always produces very interesting and robust papers, looking at their Polish screening program and showing that for people who improved, going up ideally to the 5th, the highest group of detectors, that as you improve your adenoma detection rate, your post-colonoscopy colorectal cancer rate comes down. So this is quite powerful data, suggesting that by changing the adenoma detection rate, at least as they did here with support and feedback, we can improve the post-colonoscopy colorectal cancer rate. So in terms of how we might go about improving this, I'm not going to talk about bowel preparation today, but I am going to talk about basics. And this is an idea that was developed and worked with Colin Reese's group in the Northern Region Endoscopy Group, looking at some of the simple things that we know we can do and that there is evidence for. So withdrawal time, changing position, antispasmodics, and rectal retroflexion, putting these together in an educational bundle and going out to units, encouraging them to engage with this and providing support and critically and feedback as well. This is not our idea. In fact, this was an idea ripped off from a Peter Pronovost paper. Peter Pronovost is very well known for quality improvement in the US. This is a New England Journal paper where they looked at ways of reducing the infections when central lines are placed. And again, they had a bundle of, I think, 4 evidence-based recommended interventions that they got everybody to do unless it was an emergency situation, and showed very effective reductions in central line infection. So does this work for adenoma detection? And the answer is it doesn't work for all people, but it does work quite impressively for the poorer performers. And in fact, if you read the bottom line there, so the adenoma detection rate before intervention was 7.3%, after intervention 13.9%, so an almost doubling of the adenoma detection rate. And I would ask you to think about that ratio when we look at in other interventions. So you can almost double that with an educational bundle and support. And that's fine, and so people get better. What really matters is whether they stay better, whether we make it a longer term difference to their practice. And so I'm delighted to report this data from Laura Nielsen, published in Endoscopy this year. And so I've shown you again in the red box here. So this is the poor performers, 8% detection in the blue bar, go up to 15% in the immediately after the educational bundle. And then 3 years later, we still see them performing at that high level without any further intervention. So this is a durable intervention, it's a cheap intervention, and it's an intervention you should be doing in your units. And I would put it to you, you should be doing it before you spend money on expensive devices or new equipment. If we're going to prevent colorectal cancer effectively, we need to get our poorer performers up to at least a reasonable level. And this is an excellent first step in terms. So this is a technical trick or tip on how to get your poorer performers to perform better. I'm afraid you don't matter that much, they do. So what about all of those other devices that we love to talk about? And I've shown you here, we've got add-on devices, caps, cuffs, rings, GI, advanced imaging, chromoendoscopy, dual focus fuse, and in fact, at the bottom there, we've got low cost optimizing. So this is things like position changes, water-aided colonoscopy, things that are essentially free or almost free. And this is quite a nice network meta-analysis from last year. You can see that they've combined all of those things compared to standard high-definition white light colonoscopy. And the good news is if you're on a budget, and the bad news if you're a device manufacturer, is that the majority of the effect is seen in this low-cost optimizing. The things I've just been talking about, changing position, maybe using water, having a second observer, sometimes even having a fellow in the room can support adenoma detection. These are odds ratios rather than risk ratios, and you can see that they're rather less than the 1.91 I just showed you from the educational bundle. We're looking at 1.3 ish, which is statistically significant. So in terms of how to really optimize your colonoscopic performance, either personally or more importantly, over your unit as a whole, low cost optimizing looks to be the way ahead. So improving your serrated polyp detection rate, this is the other side of the coin. So technical tricks and tips here. So we looked at this in the British Society of Gastroenterology position statement, which, as you know, has been superseded by the new BSG guidance, and that includes the Association of Coloproctology and Public Health England. And you can see Sonal there was an author. But in the position statement, we had thought about what we could do to optimize things, because we know that our ability to prevent right-sided colorectal cancer is rather less than our ability to prevent left-sided colorectal cancer. And those interval cancers that occur on the right side have a molecular genetic signature that is consistent with an origin in serrated lesions, i.e. we're probably missing serrated lesions at a high rate, and that they're contributing to that post-colonoscopy colorectal cancer rate. So here's a nice example. You can see on the left-hand image there's just a subtle in the center image, about a 2 centimeter area, with slight blurring of the vessel pattern, and you can see some adherent bile stain mucus. After washing, the lesion becomes, frankly, almost invisible, but with the application of dye, actually we can get quite nice delineation. So this is what we'd thought about in the BSG statement with the available data at that time. And Vipin Gupta, one of our fellows, has updated that in a recent review. So what's beyond white light. So there are now a couple of other things that may be beneficial. So endocuff and GI both have some supportive randomized data. Things that are definitely beneficial, so chromoendoscopy consistently seem to improve detection. The basics again, slow withdrawal, high definition instruments, split dose bowel prep. I know I said I wasn't going to talk about prep, but there is data for that, and a bit of data recently for narrowband imaging. Just to make those points, so for chromoendoscopy, so this is analysis from Alessandro Rapici in the top section here, the methylene blue MMX study, where you take the methylene blue with the bowel prep, and you can see that roughly doubled serrated lesion detection, but we see that with dye spray in more conventional mechanisms of application. For narrowband imaging, this is some data for individual patient meta-analysis, which is how meta-analysis used to be done for MBI, and you can see for non-adenomatous polyps in the right colon, which are almost all serrated lesions, we can see, again, this is an odds ratio, not a risk ratio, so a bit more conservative, 1.35 in terms of improved detection. So what about AI? AI is, we're endlessly talking about AI. So this is AI for adenoma detection. And you see a new meta-analysis out about this pretty much every week. And here you can, this is from Cesare Hassan, mostly Asian studies, but Alessandro Rapici study in there as well. And here you can see the risk ratio there, 1.44, with relatively tight confidence intervals. So you can see, to some extent, AI sits a bit between the caps and cuffs and other new devices and the risk ratio for the educational package for low performers. So most of these studies were done with expert colonoscopists. So even so, it's providing a substantial increase, mainly just using white light, beyond standard colonoscopy for high-performing colonoscopists already. So I think that this is exciting, and it's now commercially available. Almost all of the major manufacturers offer this as an option. It is, I think, going to become the standard of care. There's been concern about whether serrated lesions and particularly LSTs, relatively rare lesions in the AI training data sets, would also be well detected. In the top there, a little sub-analysis from the Hassan meta-analysis, again, 1.52, maybe even a little bit better for serrated lesions, and also good performance for LSTs. The issue is that AI is not intelligent. It's really just an amazingly good video pattern recognition system. It can't see polyps that are hidden behind folds. It can only see polyps in the field of view. And I simply showed this as some older data when we were estimating the CT colonography, how much of the mucosa you can see with a straight pullback, somewhere between 86 and 92%. So that there are significant missed areas, and it remains the job of the colonoscopist to manipulate the scope and reveal those missed areas so that potentially we get all of the mucosa into the field of view if we're going to apply AI. I think as a final thing, we need to think a little bit about our interaction with AI. And certainly for polyp detection, AI is acting as a concurrent read. It's not that we make a decision and we ask AI whether it concurs. We're actually doing it in real time. That's potentially of benefit because it might train us to see subtle lesions that otherwise we might have missed. But equally, it can make us lazy and it can make us doubt our own judgment and introduce bias. So I think while there are considerable potential benefits of AI, we need to be alive to the potential downsides as well. So finally, is polyp detection rate going to take over as a quality benchmark compared to adenoma detection rate, which we're very familiar with? And I think this may provide the answer. This is Matt Rutter's NED apricot study, which is at multiple centres in the UK. Half of the centres are going to get standard JAG support and feedback, but the other half are going to get monthly automated emails generated from the National Endoscopy Database, and with some of the hints and tips that I've been describing today to try and improve your your polyp detection rate, and look to see whether polyp detection might be a good key performance indicator, which would obviously be much more simple for us to report and action than adenoma detection rate. So what are the key messages to take away from today? So adenoma detection, we need to get the basics right, specifically with feedback for low performers, and this may become automated as we see with NED apricot. For serrated lesion detection, we still need to get the basics right, but I think there is certainly more data perhaps that advanced imaging may help. However, all of this may be superseded by AI-supported detection, and I think that AI-supported endoscopists AI-supported endoscopy is endoscopy of the future, and very soon I think it will become the standard of care. So it's going to become part of your life. You need to think about how you're going to integrate it now and deal with some of these issues, the pros and the cons. Finally, is polyp detection going to be a key performance indicator or benchmark? I think it is very likely that it's going to be a new standard of colonoscopy quality, and we look forward to seeing that data from that in the future. Thank you very much.
Thank you, James. That was a super overview of the situation there, and really encompassed all the issues with regard to improvement with technique, technology, devices, now AI. We've got one or two questions, but one of the things that I often wonder about is what you alluded to in passing, the issue of people getting de-skilled with AI particularly, but even with some devices. Are we in danger of that in terms of there being a sense of complacency that AI will catch it, whereas that real fundamental concept of mucosal exposure being primary before you detect the polyp is not quite embedded in? I just wonder what you think of that.
I think that's an interesting thought. I think it is a risk, but I think AI, and I'm sure Lawrence will allude to this later in the session, in the afternoon. It's very much a double-edged sword. You know, it can teach you. I think, although I've talked today about AI for polyp detection, as in polyps in the visual field, I think there's going to be AI quality assurance that AI in the future, the near future, will be able to measure or at least point out where you've not exposed the colonic mucosa, or where it looks suboptimal, and encourage you to go back and do that again. It'll be like a continuous mucosal assessment score, and I think those two in combination could actually be quite powerful. Whether you choose to use an add-on device to assist you in that task and make you perhaps more efficient is up to you. And I think it's a kind of fascinating time, the combination of AI devices, new scopes with 4K imaging, so working out that correct combination that's probably individual to each endoscopist is likely to be interesting and a great challenge for the future.
Yeah, I agree. It is going to be interesting, and I suppose the whole way we train people is going to change as a result of all of this, isn't it? Because it's going to have to encompass all of these modalities. What's your view on what should be the right metric that we measure people on? Is it going to be polyp detection, proximal serrated polyp detection? What would be the best thing to measure people on?
I think that metrics are twofold. That they need to ideally be simple and, if possible, automated in terms of their collection, and they need to be clinically relevant. And we saw that with adenoma detection. Adenoma detection is both associated with the post-colonoscopy colorectal cancer rate, but also we can demonstrate that by changing adenoma detection, at least in the way that Michael Kaminsky did, and not necessarily with AI or additional devices, but by improving training, certainly, we can, by changing adenoma detection rate, we can see that that leads to an improvement in post-colonoscopy colorectal cancer rate. So any new metric ideally would be easy to record, ideally automatically, and polyp detection is an obvious one. And clearly Matt Rutter, and I think he's probably right from first principles, thinks that that's going to be a good measure of meticulousness of examination, completeness, but also this idea that we can show that whatever metric is chosen, and if we choose polyps, that we should be able to link it both in association to post-colonoscopy colorectal cancer rate and demonstrate that by changing, when we change the polyp detection rate, we change the post-colonoscopy colorectal cancer rate. So I think we need those kind of two sides to it to have something that's really effective and that we can deploy at scale across the UK.
Yeah, I agree. It's just going to take some time before, by definition, PCCRCs are going to have to wait at least 3-4 years before we can do that, isn't it? There's a question about using nurses as second observers, and can we do something to utilize that better? Because there certainly seems to be reasonable evidence that that helps.
Yeah, I think second observers, be they nurses or be they fellows, can I think be helpful. I agree that there is supportive data for that. And I think that there's also a component of having everyone in the room kind of involved and focused on the procedure. You know, when you're spotting the polyps, if you're a member of the nursing team, that's also triggering you to anticipate, you know, what type of polyp is it? You know, is it a flat polyp? Am I going to need some lift? Is there going to, you know, is it going to be cold snaring or hot snaring? So not only do you get potential advantages in terms of improving your detection rate, you also get your team involved so that they are prepped and ready to support you in the therapy that follows detection. So I think that's something to be encouraged. To some extent, it also encourages people down the track to, you know, once you're starting to look at polyps and detect polyps, you think maybe actually I could scope them and I don't need the endoscopist at all, I'll be the endoscopist. So supporting people into developing as endoscopists, but potentially, and they're often from an endoscopy nursing background, I think all of that is helpful.
That's certainly been our experience, and it's been very spot on what you've just said about a couple of our endoscopy nurses who I think have got motivated, having been on lists looking at all the polyps. One last question, James, that's just come in. AI will be picking up a lot of subtle lesions, which is very good, but procedure length might increase and 2 or 2.5 point colon lists might not be adequate. Is there any data on leaving some of these diminutive polyps alone? That's the question.
Well, I think we are moving towards more therapy, and that's a good thing. Whether the list length needs to increase, certainly for our fit-based colonoscopies, where we know there's going to be a lot of diminutive lesions, or a lot of lesions generally, we now book for 3 points for fit positive because there's so much therapy. Whether we should leave these lesions behind, certainly, as you're aware, Japanese colleagues do this. They interrogate them carefully with magnification and dye, and if they think that they are truly benign with no high-risk features, they do leave them in situ and potentially have their patients come back for surveillance in due course. I think possibly our Japanese colleagues are reliant on a patient population who are willing to come back and perhaps a little bit more compliant than us. There's a tension here, and I think Elizabeth Bird-Liebman and I wrote an editorial about this. One of the Canadian groups was proposing a leave-in strategy. And I think, it's possible, but cold snaring is so safe and quick. Actually, by the time you've interrogated it and left it, for a low-risk lesion, all polyps now just count as polyps if they're diminutive. We don't necessarily need pathology. Maybe better just to cold snare them off, and that's the end of it, rather than agonize about whether it's in a more advanced lesion and whether or not the patient remembers to come back.
Great, that's really super, and thanks again for an excellent talk and a really good discussion, James. Thank you. Cheers. We'll move on to the next speaker, which we are starting the Managing Early Rectal Cancer Symposium, where we've got a good star cast assembled. And the first speaker is Dr. Adolfo Parablanco. Adolfo is well known to most of us in endoscopy circles. He's a consultant gastroenterologist at Nottingham University Hospitals and the head of service for endoscopy and honorary assistant professor at the NIHR Nottingham Digestive Diseases Research Unit. So I'm really looking forward to Adolfo kicking off the symposium with endoscopic approach to early rectal cancer. Thanks, Adolfo.
Good morning. Thank you very much for the invitation to this very important and nice virtual meeting. Going to review a few points in 15 minutes about the endoscopic treatment of early rectal neoplasia. And in the end, diagnosis remains one of the main parts of the treatment, because we have to find the lesions, we have to assess them correctly and decide if they are for local endoscopic treatment or not. When we know that there's a rectal polyp, we have to look after it very much, especially until we have evaluated it correctly. So let's be very careful with the rectal examination, and mainly when we pass the endoscope to assess the polyp, let's pass it very carefully. If we make it bleed, we won't be able to see the pit pattern or to do a proper evaluation. Let's be careful with the water jet, not applied with high pressure, just on the polyp site. And it's important to describe the features of the polyp: size, location, macroscopic classification. For LSTs, the Kudo classification, estimate the size as compared with a biopsy forceps or with a snare, the location, which wall of the rectum is affected, and how far from the dentate line the polyp is. We have to describe all this in the report. There are different classifications for the assessment of the pattern, not just the pit pattern, but also the vascular pattern with virtual chromoendoscopy. This is one of the first classifications described, a nice classification, which is easy to use, but it's not very useful probably in order to determine if the lesions have high-grade dysplasia or subtle invasion, or if there is a deeper invasion in which endoscopic or local treatment wouldn't be acceptable. And for this purpose, the JNET classification, the Japanese classification, is trying to find subtle changes which tell us if the lesion has an invasion deeper than 1 millimeter, 1,000 micra or less. That is one of the factors which will determine if the lesion can be removed endoscopically. So they look very carefully at the vascular findings. When we receive a polyp for endoscopic treatment in the rectum, we have to first assess it very carefully and decide if the right thing to do is to remove it. So let's not get the injection needle in the snare from the beginning. Let's observe the polyp. Let's make the best of the scopes we have. Ideally, we should have some magnification endoscopes to assess the polyps. This polyp has a clear boundary, a clear demarcation line with a very irregular vascular pattern, with amorphous pattern, with scattered vessels. This means that there is a deep invasion. This is not for endoscopic treatment at all. Even for smaller polyps, we have to be ready to find the signs of malignancy. This was a 5 mm rectal lower sigmoid polyp with an erosion, and we wanted to be aggressive in the treatment, not just with a cold snare, but with a method I will show you later. And if we think that the lesion will be for endoscopic treatment, we ideally shouldn't take biopsies that may hamper the endoscopic resection at a later stage. So let's just take biopsies if we are really convinced that the lesion is malignant. Otherwise, it's okay to leave it without any biopsies and to discuss in the SPEC or the lower GI MDT. If we take biopsy, we should take them from the worst looking area, like this one pointed out by the arrow, which was zoomed and clearly showed a malignant invasive pattern. With regards to the resection techniques, endoscopic techniques, there are increasing number of techniques. The most widely used one has been, still is, the endoscopic mucosal resection. Can be done with a snare and injection in one piece or multiple pieces. We have hybrid techniques which help us remove the lesion and block or completely by making some small or circumferential incision around the polyp and the normal mucosa to anchor the snare. We have underwater resection, which is becoming also very popular, and we have endoscopic submucosal dissection, in which we use special knives to make an incision around the polyp and to dissect the submucosa and remove the lesion in one piece. We have a full thickness resection techniques with special clips over the scope clips. I'm not going to discuss this today. And we have techniques to just scrape the polyp off from scarred polyp, from polyps which have been treated multiple times, and we have a handful of them in the rectum. EMR has a very good effectiveness. It's a very useful technique. It's not very difficult to learn, or at least the learning is somehow established. Most of the lesions are removed completely. The main problem is the recurrence after a couple of months, especially when the lesions are removed in multiple pieces. And there's a 1 to 3% rate of invasive recurrence in such polyps, mainly when they are removed piecemeal. So this is a case I want to show you about EMR. This is a suspicious polyp because it is large. This is a lower sigmoid as well. There's a depression, but in a previous endoscopy, the pit pattern and vascular patterns were assessed and there was no clear findings of malignancy. So this case was done underwater, but with proper injection, good lifting. The lesion felt quite soft, so I tried to remove in one piece with using the right snare, right size, trying to see the normal mucosa around the polyp, and then we can cut it, ideally with not with coagulation. It provides less clear specimens, and we have to be ready to treat the complications whenever we do an endoscopic resection. This was an arterial bleed in the lower sigmoid, so I decided to treat this with a hemostatic gel, with a Purastat, and retrieve the specimen. That was a very important point to consider. Sometimes when there's bleeding, we can lose the specimen. So we retrieve the specimen. That's the vessel which was bleeding on the back of the specimen. And when we passed the scope again, the bleed had stopped, and then we had enough time to suture the site with clips. And later on, we will stretch the polyp on a cork. The polyp initially on stretch was 2 centimeters in size, but we know that when it was in the colon, it was bigger. It was a 4 centimeter polyp, which was removed completely with R0 resection, and it only had low-grade dysplasia. So EMR can be very effective, but sometimes in order to achieve an en bloc resection, we want to use hybrid techniques to help us apply the snare more confidently. We can use dedicated snares or normal snares. We make a small incision and then we put the tip of the snare there. Like in this case, it's a rectal polyp. It was very suspicious because there was a depression and the vascular pattern was irregular. This is many years ago already in Oviedo in Spain. The erythematous area is the most suspicious area, so retroflexion is very helpful for the removal of and assessment of polyps, and some studies show that when retroflexion is used, the resection can be done quicker. Especially this was described for ESD, but it's also very useful sometimes for EMR. We can see how the white round snare is open well around the polyp, trapping normal mucosa. Ideally, we should see what's going on and see that the normal mucosa is involved within the snare closure. And we can cut it, and this led to a block and complete resection. The polyp had high-grade dysplasia. We can make wider incisions as conferential incisions as well, and with dedicated knives or with the tip of the snare, and then put the snare on that groove. And we can use also a biopsy forceps to achieve that. And this is called the hybrid biopsy EMR, which we described. And for this small polyp, that's what we did. We wanted to get a normal mucosa as well and go deeper with the snare. And this polyp had a submucosal invasion already. Underwater EMR was described by Bimber 8 years ago. The rationale is that that the muscle layer will remain flat when water is applied, and this should decrease the risk of perforation of trapping the muscle layer. And in fact, in this meta-analysis, with more than 500 cases, there were no perforations. However, perforations can also happen with underwater resection, so we have to be careful. The complete resection rate is at least as good as with EMR, and the recurrence rate is probably better than with EMR. ESD, we know that it was described in Japan. We tried to remove the lesions in one piece. One of the difficult points is training. Nowadays, we already have experts in the Western countries, and in these North American series, the results for rectal polyps was as good as we hear from Japan and from the Eastern countries, with a very low recurrence rate, decent sized polyps, and a very good en bloc and R0 resection rates. This is a typical case of rectal ESD. This case didn't look adequate for endoscopic mucosal resection because it was large, it was suspicious, there was a depression in the center. And we made a semi-circumferential incision with needle knife type. Is a dual knife, and gaining access to the submucosa is one of the challenges. We have to try and avoid cutting the muscle layer, and different techniques are being developed to facilitate this, like making tunnels, making pockets in the submucosa. We can also use traction techniques to facilitate the observation of the submucosa. And this is the clip band technique, in which we use 2 clips and a rubber band. We described this for gastric ESD, but it's being used extensively in the colon. And usually we put the second clip on the opposite wall. We can also use a clip line technique by using only one clip and a thread and pull it from outside. And once the endoscopist can see the submucosa, things become easier. This is a scissor type knife, which is time consuming, but it's very safe. And we can coagulate the vessels as we find them. And this is the resection bed. This lesion had a high-grade dysplasia. The main difficulty in this case was the sedation, because the patient tolerated it very well, but it was long, more than 2 hours, and the patient was restless in the end. So sedation for ESD, I think, is an important issue, which is the best way. And just to show you the last case in which this polyp was referred for endoscopic mucosal resection, because they said it was a pedunculated polyp, but in fact it was sessile. And even if we tried to do EMR, that's what had been planned, probably we should have started with ESD, because the EMR didn't progress well. The specimen we obtained was very poor. The snare was not big enough to trap the lesion and block, and we had to do it in multiple pieces. But as you can see, the specimen is really poor. I'm sure that pathologists will be thinking that this is a crime. And then finally, we decided to switch to the ESD. In fact, the snare even got tangled in the polyp, and it was challenging, and it was clearly not the right thing to do. So we prefer to complete the procedure in the same session, and then with a scissor-type knife, in 60 minutes, more or less, we managed to remove the polyp. This was quite bulky, so the good thing of that is that the own weight of the polyp makes some traction. Once we have made the incision, the circumference, and done some dissection, the weight of the polyp applies traction, and it becomes rather simple to do. We clipped it, and we can see the specimen, the small bits for the EMR, and the big piece for the ESD. So we have to be ready to change our mind. Just a few words about the endorotor, which is a probe with rotating microplates, which allow for shaving the surface of the polyp from the fibrosis, from the scar, with suction, and also with flush of saline. And I think this is the first series described by Bandari's group in Portsmouth, showing that in a few sessions, these difficult polyps with multiple previous treatments were managed endoscopically with a safe profile. And this is just a case which had multiple previous endoscopic treatments. Sometimes it's patients who had a surgical treatment as well, transanal operation. We inject saline with adrenaline to reduce the oozing later on. And then we use this probe. So this was, I think, was my second or third case. So we have to learn where to put the tip of the probe, but it needs a different sensation. We are not used to suctioning polyps. The specimens are sent in many tiny pieces, so this is not for suspicious polyps. We have to confirm with biopsies that it is not a malignant lesion, but we can clearly use this technique for these difficult polyps. Finishing now, we have seen the advantages and disadvantages of EMR and ESD. EMR, we are used to using it, but there are some cases with recurrence, and some of those recurrences are invasive. ESD, we have to learn how to do it. It takes time. We have to decide which is the best sedation method for these patients, maybe even general anesthetic. And we have to be careful not to cause complications, but this is a very good technique in the expert hands. Our colleague is going to tell us about the surgical management of rectal polyps. There are some studies have been done already, some others are ongoing. There's a randomized trial comparing transcendental surgery with ESD for rectal polyps. So far, we know that the results are probably comparable. There may be some differences in recurrence and in complications, but we need more data. And I think that it's very much about local availability and about discussing the cases in the proper setting in the spec meetings if we have them, and if not, in the lower GI MDTs. In conclusion, ladies and gentlemen, diagnosis is very important for the treatment of rectal lesions. We should apply the technique tailored to each case, and we need more evidence in order to have a better understanding about when to use which techniques, if surgical or endoscopic. Thank you very much.
Okay, that was absolutely super. Thanks very much, Adolfo. That's a wonderful start with endoscopic approach to early rectal cancer. We're going to take questions at the end of the symposium, and I'll ask Joe to introduce our next speaker, please.
Okay, morning everybody. Next we're going to go with Mr. Mike Davis, who's one of our senior colorectal surgeons in University Hospital Wales in Cardiff. He specialises in minimal access surgery and has developed a tertiary referral centre really in Cardiff for transanal endoscopic microsurgery. So who better to tell us about surgical management of early rectal cancer and complex polyps. So we're going to go over to a video from Mike and hopefully he'll join us later.
My name's Mike Davis, and I'd like to thank Sunil Dalwani as the organising president and the committee for inviting me to give this presentation on the surgical approach to managing early rectal cancer. I hope to cover a number of areas as listed here, with a little eye on the future at the end if we have time. It's fair to say that early rectal cancer's boundaries are slowly expanding, and this consensus statement from 2015 suggests that we should be thinking about early lesions and organ preservation, moving away from just the very, very early stage tumours. There may be ways that we can do that, which I'll allude to later in the presentation. Why has this become more important now? Well, really, bowel screening has come along, and within bowel screening, a high percentage of tumours are at an early stage, and this applies, of course, to the rectum. So we're dealing with more early stage tumours, and we need to know how to deal with that. In fact, when we look at the data from the NBOCA audit from last year, surprisingly, more than double actually come from symptomatic GP referral, but nevertheless, bowel screening is expanding, and this is an important and increasing area. So what about the assessment of a patient with early rectal cancer? Well, these are beautiful pictures sent to me by Neil Hawkes from a patient he referred to me some years ago for TEMS surgery for an early rectal cancer, and using different modalities endoscopically, including dye spray, allows helpful assessment of these lesions. What do I want to know from the endoscopic assessment? I want to know, does it look like a cancer? Has it got malignant morphology? Where does it lie in the rectum? How far from the anus? And also where on the circumference, because these can influence the management surgically. And what is the size of the lesion? And we'll come back to that later. Staging, as always, involves MRI of the pelvis. But T-staging is slightly vague, I would say, with MRI, except in very experienced hands. An endorectal ultrasound scan can have an additive benefit. And of course, CTAP for looking more distant metastases. All of them have a role, but all of them have a degree of variation in accuracy. Clinical assessment's also important. Where does the lesion lie relative to the anus? And also it's important to know where the lesion lies relative to the peritoneal reflection, which can influence the ability to undertake surgical management. All of this information is brought to the MDT, which is crucial in these patients. And there we discuss treatment options, and we'll come on to those now. And it's fair to say that really the options are multiple, and it's potentially a Venn diagram of these different options with overlapping options being considered for some patients. So whilst I may talk to you about the surgical approach, I have to include other areas as well. Main surgical options are either to resect the rectum or local excision. And with rectal resection, there remains the potential for a permanent stoma. Focusing now on rectal resection, majority of this is now done with minimally invasive surgery, a nice small cosmetic incision, a reversible stoma, you know, all well and good, and seemingly very attractive. Has the advantages that the primary tumour is clearly removed, with an early cancer, clear resection margins, lymph nodes are removed, and therefore we've got accurate staging and accurate treatment. However, there is a downside. 10% anastomotic leak rate, 12% pelvic sepsis, 2% mortality. These are the sort of typical figures for resectional rectal surgery. 85% of patients will have to cope with a stoma, and even where potentially reversible, a third still have a stoma 18 months after surgery. There are many risks associated with rectal resection. We've discussed anastomotic leak, pelvic nerve injury, bleeding, a risk of a permanent stoma in 10 to 30%. This is an important study looking at patients who had treatment for colorectal cancer at 12 and 36 to 36 months after diagnosis. This is a huge study of patients looking at their function. And what you see is that over a third of patients had significant problems with continence after colorectal surgery. Many were socially distressed by the presence of a stoma. Many had sexual difficulties, 25% in rectal cancer. And if we look at this data from the Dutch rectal cancer trial, which looked at radiotherapy and surgery for rectal cancer, a very significant percentage of patients had real functional problems. So there really is a downside to resection. Whilst it can give us good pathological control and important information, there are significant functional and complications associated with this type of surgery. It could be suggested that it may be, to a certain extent, a sledgehammer to crack a nut. All the time we're looking at the balance of oncological safety versus function, organ preservation versus the risk of recurrence. So we come to the second option, which is local excision. And this is the type of instrument which we use. This is a TEM scope, transanal endoscopic microsurgery. This is a surgeon sitting down comfortably for his afternoon's work, able to view pictures on a screen. Here's a typical image seen through the scope of a polyp, starting to dissect around and ultimately producing a full thickness excision. And this is an early rectal cancer pinned out after removal. So what are the outcomes of transanal endoscopic microsurgery? This is data from the UK TEM trial, which is a few years old now, but gives you an indication that although there are complications, generally the incidence of these is very low, but not without a mortality rate. If we look at the functional outcomes scored by continence scoring, fecal incontinence score, what we see is that there is a transient incontinence associated with TEM surgery, but ultimately no long-term effects on anorectal function and excellent long-term quality of life scores. Compare that to what we described for resectional surgery, a low stoma rate, a lower mortality rate. This is a seminal paper produced in 2009, and I accept it's some years out of date, but the results continue onwards now, and I think it's still relevant. This compared transanal endoscopic microsurgery, local excision, versus rectal resection of T1 tumours. What we see is a very low rate of recurrence for resectional surgery. Then we start seeing one of the potential problems with local excision, which is an increasing recurrence rate. What may surprise you to see, however, is survival is no different, particularly the cancer-specific survival. This is a more recent review from colorectal disease 2013, looking at multiple such trials. Again, you can see the forest plot, rate of recurrence, favouring resection, rate of post-operative complication, much less for TEMS surgery. Overall survival in favour of TEMS surgery. All of this was ultimately put together by a helpful model looking at local recurrence, which is the Achilles heel of local excision. And what we see is this table, which shows as we enlarge in terms of a early rectal cancer, the size is bigger or the stage increases, that the risk of local recurrence starts expanding significantly to places which we would all, as certainly rectal surgeons, feel very uncomfortable. So why does local recurrence occur? Well, this is the problem. This is Kikuchi staging, which describes how the tumour spreads as it enlarges through the submucosa. SM1, SM2 deeper, SM3 deeper again. And for each stage you go down through the levels of submucosa, you see that there is an increased rate of lymph node metastases. And what you also see, if you look at lymphovascular invasion, is a similar significant increase. So if we can choose early tumours, ones with no lymphovascular invasion, we can significantly reduce the risk of lymph node metastases and therefore local recurrence. Other measures are also looked at, and importantly, width of the lesion, depth of the lesion are also key factors in reducing risk of lymph node metastases and therefore local recurrence. What we can potentially do is risk stratify lesions, and if we choose the right early lesions, we can achieve same outcomes, but obviously with a much lower morbidity as with resectional surgery. So what do we do with patients? We take them, we discuss these options, and we say to them that rectal resection remains the gold standard, but it's a morbid procedure and there are long-term quality of life issues. We mention local excision, and we advise them of the alternative, but we have to be very careful in terms of case selection, looking at the different aspects that we can use to assess the patients. And in certain patients, we consider non-surgical options. Within our MDT, it's key that there are many specialists who aid the management of these patients. They're not straightforward for the reasons we've mentioned. We assess our patients. Sometimes it's obvious visually, but we find that CPET testing and anaesthetic review can help define those patients who are fit enough for major surgery. Ultimately, we bring the options to the patient, and as with the recent addition of patient consent, we have a careful discussion, discussing the risks and benefits of the different approaches, and ultimately come up with an individualized patient care. There are certain patients I don't recommend surgery. If there's a very low tumour and the patient declines APR, which would be treatment, and sometimes patients really aren't fit enough for this, they're too frail. And certain patients actually refuse to have rectal surgery, refuse to have a stoma. What are the options for these patients? Well, we get some idea from the TREC trial that short course radiotherapy can be helpful in selected patients. Long course chemoradiotherapy from the Harbor Gamma data, watch and wait data shows that in this wider spread group of patients, which are not all early cancers, we can still get a significant complete clinical response, which is actually higher in early tumours. But contact radiotherapy really provides something helpful in frail patients with 80 to 90% local control and 79 to 90% 5-year survival, which may not seem great for early tumours, but in a frail group of patients, I think these results are very good. So from what I've said, you can see that whilst we have a surgical approach which involves resectional surgery, local excision, very much there's a combination potentially of a series of options depending on what's appropriate for the specific patient. There's certain problem scenarios when managing early rectal cancer, and I'd just like to quickly outline these. The higher risk locally excised tumour presents a problem. We look at the tumour when removed and we look for certain higher risk features. If these are present, then we know that the risk of lymph nodes is higher. We look at our chart and we look at the size and we look at the stage, and then we discuss with the patient about their options. And whilst as rectal cancer surgeons, we look at a local recurrence rate around these single figures, often patients are happier to say, well, 15% risk of local recurrence, that means 85% chance that I'm cured. I don't want to have a big rectal cancer operation on the basis of a 15% chance. They're happy to stick with that. The other aspect of rectal resection after TEM surgery is that it can increase the risk of APR. So there are certain patients who will go ahead and accept a rectal resection. The oncological outcomes are good, but there is potentially an increased risk of stoma formation having operated on the rectum already. Radiotherapy is a useful option in these patients, and this rather busy slide summarizes that. What we can see is if we add radiotherapy to more advanced stage tumours, then we can reduce the risk of recurrence to more acceptable rates, and certainly that's an option which many our patients choose if they have a higher risk tumour which has been excised by TEM. All of these patients we watch and wait with close surveillance, irrespective of how we ultimately manage them. The other problem scenario is the unexpected cancer. And I sometimes think that I'm looking at the wrong end of the telescope like this lady. If I can just outline a scenario. We see many rectal lesions when we're scoping patients, and the question is which of these could be a cancer? The risk is if we just remove all rectal polyps without some thought, we have a non-full thickness excision, there's a significant risk of margin involvement. The margin's close or uncertain. We may have added some heat injury to the rectum at a site of potential anastomosis, and all of these increase the risk of rectal resection and permanent stoma. So what we do in these patients is assess for high-risk features. We assess the size of the tumour, the resection margin, and then try and advise the patient accordingly. If they're high-risk features, we recommend rectal resection. We occasionally recommend excising the base, but rebiopsy first is worth thinking about, since often there isn't an involvement present. There is no residual cancer, and we also consider radiotherapy and watch and wait as before. But as with all of these things, avoidance is the best option. So when faced by this, I just plea that you stop and think, and just think of a colonoscopic plan. If you're uncertain, if there are any high risk features, don't remove the polyp, just measure it, take some pictures, video if possible, biopsy it, and then live to fight another day, and then consider it in the MDT. So in terms of approach to early rectal cancer, I reiterate that rectal resection remains the oncological gold standard, but there are significant quality of life issues. A careful MDT-based selection of patients for local excision is crucial, but can be very beneficial to patients with much improved outcomes in terms of functional outcomes. There are surgical options which should be considered for those who are not fit for surgery. And ultimately, it's about individualized patient care. What about the future? Well, this is coming. This shows what's going to happen once COVID has passed and the fit threshold is reduced and age expansion is achieved within bowel screening Wales. We can see this massive increase in screened patients, which undoubtedly, having seen the data at the beginning of this presentation, will correlate with more early rectal cancer, more early lesions. And we therefore need to have a very good route for managing these patients. Ultimately, with these patients, we need to consider the balance, removing the cancer effectively. A portion of patients who fear their cancer coming back might not fit well with local excision, versus the patients who are so keen not to undergo rectal cancer surgery and the risk of a stoma. Thank you very much.
One.
Thank you very much, Mike. That was brilliant. For those of you who are watching, we are going to do questions and answers at the end of this session. Mike hopefully will be able to join us again for that. If you're still referring to the original programme, unfortunately we're not going to be joined by Chris Parry, but we're going to proceed with our next talk, which is going to be from Dr. Mallory Morgan. I'm sure that most of you are familiar with Mallory. She is our wage pathology representative. I hope she knows that. Highly respected and well sought after. We're always asking her to contribute to our talks, and she's always very, very well received. So thank you for this, Mallory. She's going to talk to us about the pathology of early rectal cancers, hopefully explain it all to us. So over to Mallory, and we'll speak to her again at the end. Thanks.
Thank you for asking me to talk today. I'm very lucky to work as a pathologist in Cardiff, where there is local excision TEM surgery and also the National Referral Centre for Bowel Screening Wales. So there are complex polyps, meaning that I get lots of experience with these types of difficulties in pathological interpretation of early rectal carcinoma. This talk is based upon a talk I gave for the SPEC meeting run through the Pelican Foundation. Whilst confirmation of adenocarcinoma with some assessment of grade is the limit of the pathologist's involvement at a diagnostic stage in most cases, for those PT1 cancers, which we are seeing more because of the bowel cancer screening programs that are excised by polypectomy or local surgical excision, then we have an additional role in predicting which one may have lymph node metastasis or at risk of developing lymph node metastasis, which we know the literature records as being present in about 9 to 18% of all PT1 cancers. The MVT therefore uses our information to decide which cancers can proceed with watch and wait type assessment and which one need immediate surgical or radiotherapy additional management. This can be information can be combined into a risk assessment for patients, looking at the adverse prognostic features, which I will talk about some more, and providing them with a risk, which can be used obviously in conjunction with their other clinical problems and their wishes. To do this, we need you to provide as much accurate information as possible. Please send us the endoscopy reports so that we can cross-correlate it with the endoscopic findings, particularly important if there are more than one polyp, especially if there's more than one polyp from the same area of bowel.
Please tell us whether or not your intent was to excise this, be it piecemeal or en bloc, and whether or not there has been previous biopsy, because scarring and prolapse that occur after biopsy can impact upon making a diagnosis of adenocarcinoma. The diagnosis of adenocarcinoma on biopsy material is difficult in itself. This is often due to sampling issues, where whilst occasionally we will get biopsies with clear submucosa and submucosal invasion seen to make a diagnosis of adenocarcinoma, in other cases we will get more superficial biopsies, and whilst there might be high-grade dysplasia present, we can't exclude the presence of underlying adenocarcinoma because that material simply isn't there to do it. There aren't enough lymphatics in mucosa for the risk of carcinoma in situ in itself to be recognised. There are obviously a group in the middle, so if we see desmoplasia or adjacent thick-walled vessels, we will make a diagnosis of adenocarcinoma, but it still leaves this group where we will say there is suspicion of invasion only. There are potential adjuncts to diagnosis in the use of immunohistochemistry for type 4 collagen and MMP9, but they are not in regular use. Diagnosis of adenocarcinoma in a locally resected polyp is also tricky, particularly if you have tumours from the sigmoid colon, where you may get the presence of pseudo-invasion or epithelial misplacement. This is due to trauma, and as I am showing you here, we'll have various features that help us differentiate, but sometimes they both exist together. I hope you can agree that you don't need FRC path to see the difference between this area of pseudo-invasion or epithelial misplacement and this here, which is true invasive adenocarcinoma. So what are these poor prognostic factors? Well, we recognise them essentially that they fall into 4 groups: the morphological appearance or the grade of the tumour, and whether or not they have tumour budding, whether or not there is invasion of lymphatics or vascular invasion, the size / area of the tumour, and whether or not these are excised. All of these, with some exceptions, as we'll talk about, are included in the Royal College of Pathologists data set, which is the gold standard reporting pro forma for locally excised carcinomas. If you're not getting all this information on your reports, then you should be going back to your pathologists and asking for it. Briefly mention that we are lucky compared to other organ sites as GI pathologists in that almost all of our tumours in the lower GI tract are adenocarcinoma, probably the exceptions being signet ring cell carcinoma and mucinous adenocarcinoma, which are subspecialist types recognised if more than 50% of the tumour shows that morphological appearance. Tumour grade is important. This is a poorly differentiated tumour. Well differentiated tumours will have simple glandular structures. And the recognition is really that we divide a line between poor differentiation, as it is a significant adverse risk factor, and we're looking for any degree of poor differentiation, most commonly seen at the invasive front. The problem is that there's poor inter-observer variability, with poor agreement and a kappa of only 0.07 between even experienced GI pathologists. Is there a means of improving upon this? Well, there's recognition that you can see what is defined as poorly differentiated clusters as a more objective evidence of poorly differentiated carcinoma, and they are malignant cell groups of more or equal to 5 cells without a gland profile. They have been described by many as a kind of micropapillary pattern. And you're looking to grade that depending on the number that you see within a medium range objective. This has, if you see grade 3, 17.4% risk of lymph node metastasis versus 6.9% for the others, first described by Ueno et al. In this paper, and has much better kappas than just giving it a grade. Tumour budding is a phenomenon that you will probably, as clinicians, be familiar with pathologists talking about. We often report it, even though there is not an absolute required to do so. And the reason we do that is there is increasing evidence that if we do this correctly, it is of importance. We are looking for a single tumour cell or a cluster of less than 5 cells. And really what we're looking at is the epithelial to mesenchymal transition. We're looking in this area here where we will see small groups, and they are often hard to differentiate from their surrounding stroma. There is a consensus committee which has published this paper recommending reporting of tumour budding and how to do it appropriately. It's not the same as tumour grade. It can be informed by the presence of immunohistochemistry, these cytokeratin markers showing them here, but the recognition is that we can do this on H&E staining, and therefore we don't need anything special to do that. The recommendation is that we need to grade the budding count between low and high, and that if we do this properly, it's an independent predictor of lymph node metastasis in this group of colorectal cancer. It is interesting, also an independent predictor of disease-free and overall survival in stage 2 colorectal carcinoma. And it has an association with other poor risk factors such as vascular invasion. Dependent on whether the polyp is pedunculated or sessile, there are particular T1 substaging systems allowing assessment of risk. Haggett system evaluates pedunculated polyps, and you can see that it's really when we get to level 4 invasion and to a lesser extent level 3 invasion that the risk arises, so that in superficial invasion into the head or the neck of the polyp has a low risk. The Kikuchi system evaluation divides the submucosa into 3 levels, and it is once there is SM3 invasion that the level significantly increases. There's been further attempts to semi-quantitate this system and divide it into further levels of risk, for example, into 1A, 1B and 1C, working with the width of invasive malignancy. Whilst SM1 and SM3 lesions may be more clear-cut, what about SM2 lesions? This is a difficult grey area. We can see if we include it with SM3, then there may be a risk of unnecessary surgery. However, if we include SM2 lesions with SM1, then there is a risk of undertreatment. For all these reasons, T1 substaging has its challenges. It shows a distinct inter-observer variability, although with better kappa with Kikuchi rather than Haggett staging, the submucosa may not always be fully represented. It doesn't work for piecemeal resections, and poor reorientation is a problem, particularly in these resections. And there's obviously the difficulty in assessing subpedunculated lesions. In recognition of these difficulties, then an alternative method of measuring the depth of invasion beyond the muscularis mucosa and the width of invasive malignancy provides us with a different risk assessment system, recognizing that if there is more depth and width of 2 millimeters and 4 millimeters respectively, then there is a 20% risk of lymph node involvement. If we look at a 1 millimeter cutoff rather than a 2 millimeter cutoff as an assessment of risk, we can see there's a strong increase in relative risk, but this comes with high sensitivity but low specificity. In other words, more unnecessary surgery. There are problems still with this Japanese way of T1 staging. It's underestimating the lesion if it's piecemeal or incomplete. Identifying the muscularis mucosae comes with its own problems, and you need to identify the point of origin to decide where to measure your depth, and particularly a problem in pedunculated polyps. There are some adjuncts that can be helpful. We can use specific staining. This is Desmin staining, which highlights smooth muscle. And here we can see that it highlights the smooth muscle, allowing us to measure the depth of invasion. This improves the Kappa evaluation, but is still only poor. Double reporting may be helpful, including agreement of measurements to improve the variability. A Leeds study published a few years ago looked at 207 PT1 cancers with assessment of risk developed on the idea that an area of submucosal invasion is better evaluation. They evaluated more than 35 millimeters squared as best predicting lymph node metastasis. Whilst looking for lymphatic invasion, illustrated by the use of an immunohistochemical style D240 here, and here, together with venous invasion, is often straightforward. There are challenges in doing this. So the presence of retraction artifact, necrosis, tumor plugs obscuring the venous wall, all make assessment difficult. Why is it that we record lymphatic and venous invasion separately? Well, this paper illustrates that actually the relative risk for venous invasion is lower than that for lymphatic invasion when separated out in this meta-analysis. The Royal College of Pathologists requires us to call everything that has a less than 1 millimeter clearance as an R1 resection. Assessment of this, however, is difficult. It's made particularly difficult by the diathermy zone that we see at the base of polyps. In actual fact, there is evidence there to suggest that rather than giving a precise measurement, that we can accept an excision of less than 1 millimeter as long as it doesn't involve the coagulative zone. Of course, we have to recognise that the coagulative zone extends beyond that we see within the specimen. So in summary, poor prognostic features for lymph node involvement are poor differentiation, tumour budding, Kikuchi stage 3 and probably 2, Haggett stage 4 and possibly 3, depth more than 2 millimeters and width more than 4 millimeters of involvement, and as just discussed, margin involvement. So what of new biomarkers and what the future hold for further assessing risk for each patient? An inverse relationship with tumour budding is seen with tumour infiltrating lymphocytes, so less budding, more lymphocytes. And this recognises the importance of the epithelial mesenchymal interface that we were talking about previously. Peritumoral lymphocytes are seen more commonly with microsatellite instability, as is poor differentiation. With NICE guidance now requiring microsatellite instability or mismatch repair protein immunohistochemistry to be performed on every colorectal cancer, then actually it is not every poorly differentiated cancer that will have a risk of developing lymph nodes, but only those that are macrosatellite stable. There are no statistically significant molecular alterations defining lymph node risk, although lymphatic invasion is associated with BRAF mutations, and there has been P53 mutations seen more frequently in high-grade tumour budding. I will leave you with this last slide, just reminding everyone that you should be expecting pro forma reporting with up-to-date guidelines, all data items included, and double reporting of your PT1 cancers to improve accuracy. Use local expertise, and if that's not available, there are handily 2 pathologists available within the bowel cancer screening program with specialist expertise and expertise beyond that in
Well,
Brilliant. Thank you, Mallory. Welcome back, everyone. We're going to be joined hopefully by some of our speakers, and we've got some questions that have already come through. So we're going to start. I think, Sunil, you've got a question for Adolfo.
Yes. So one of the questions that we've received,
Yes,
one of the questions that has come in is about the caps we used for the procedures that Adolfo was showing. And very briefly, Adolfo, if you could give an idea to the audience about how we choose the caps, and that would be very helpful. And when we decide that caps might be helpful.
yes. Can you hear me well?
Yes, okay.
Sorry. Excuse me. Okay, sorry, Sunil. Yes, so for ESD, they are part of the kit that we should use because it helps us find the space in the submucosa. So it's a must for ESD. Unless if we apply traction methods which help us see the submucosa better, we might not need them, but they are always used. They are straight cups or conic type cups. The conic type cups make it easier to find the initial space in the submucosa and make it to them. For EMR, you can use them or not, but particularly I use them quite a lot, especially after I came to Nottingham, where Chris Ragunat always used them. And the advantage that they give you a bit extra space from the tip of the scope to your aim to the polyp. So it helps you in stopping the bowel movement, treating the bleeding, and also finding some space between the polyp and maybe a fold or a acute angle that may make the view complex. But in EMR, we use straight cups. Usually only 2 millimeters of the cup comes out of the endoscope. For ESD, there are different cup, conic or straight cups. I hope it was.
Okay, brilliant. Thank you. That's really helpful. Joe, did you have a question from the audience?
Yeah, another question from the floor. I think it's from John Green. Adolfo, what would make you choose an ESD versus a TEMS?
Mm-hmm. Yeah, so as we briefly discussed, and I'll call it the surgeon in greater detail, there are some studies, some other studies which will provide better evidence are ongoing, but we still need more evidence. So I think it depends on, of course, if the lesion is suspicious, that's the first thing. If it's suspicious, then we should go for en bloc resection. En bloc resection should be by ESD or by some of the transanal techniques. We didn't mention the TASER, which is a combined surgical endoscopic method developed in St. Mark's, but it's very good as well. It depends on, I think, on local expertise, on how long the procedure is expected to take, and what's the availability in terms of sedation or general anesthetic, and discuss it with the patient as well, and how close the lesion is from the anus and if it's expected to be painful or not. But I think it depends mainly on your local expertise and on the suspicion of malignancy of the lesion, and also in the discussion in the spec meeting. So in our case, in our hospital, our surgeons are very experienced in the rectal treatment with TEO. So we share the cases as a good team. But we always think what's best for the patient.
Great. Mike, can we bring you in, maybe just to add anything to the end of that discussion? And I do have another question for you as well, Mike.
Yeah, I think my view is that the current evidence base says that we need margin on cancer. And I don't believe, and I don't think the evidence as published at the moment shows that we can get a confident margin with ESD. And that's why we undertake a full thickness excision with TEM. So at the moment, I would say that until we have that evidence, which may be there, and I think this is blurred by the Japanese data where they confuse intramucosal cancer, which is high-grade dysplasia, with cancer, where they have very, very good outcomes with ESD, with cancer in inverted commas. And I respect their incredible expertise. At the moment, our evidence is we need margin. And until we don't have that evidence that we don't need that margin, I think we are potentially compromising the patient by doing ESD, because if they have a cancer, we're not getting a margin and we're increasing the risk of recurrence. And we're also not enabling malaria to actually stage the patient properly because we don't have the full thickness of the wall. And I know that's controversial, and I can see Sunil getting very agitated, but that's my view as a surgical oncologist.
Well, we can keep Sunil on mute. That's not a problem.
Perfect.
Can I say
Go
something?
on then.
Yes,
Go on.
so of course I completely agree. If we think that the lesion invades beyond the superficial submucosa, then best thing for the patient is not to do an ESD. But if after careful assessment, which we know that in expert hands and with a good endoscope with magnification and chromendoscopy, we think that using the classifications available, that the lesion has high-grade dysplasia or superficial invasion, so no amorphous pattern, then I think either technique is all right. When we feel that it is more invasive than that, we will not go for an ESD, unless the patient for certain circumstances will not have an invasive treatment. And it has been described by some Japanese authors after discussing with the surgeons that even patients who had a mild invasion to the inner circular muscle layer underwent an ESD and a further radiotherapy to complete the treatment just in extreme cases. But of course, anything invading beyond the 1 millimeter, as expected by endoscopic assessment, we will leave it to the surgeons, of course.
Thank you. Sunil, did you want to say something?
Of course, the difficulty is we just don't know that. I mean, I respect your
Thanks,
ability
sorry
to
about-
look at the lesion, to look at its depth, but I think at the moment we really don't consistently have the technology or facilities to actually measure that depth. So each time you have a cancer, we need to treat it, say there's uncertainty in terms of the depth, and treat it as a cancer.
I think
until we know
that
otherwise.
that's really well. So I'll withhold anything else in the interest of time. I think that was a nice summary, both from Mike and Adolfo. So thank you both very much. I think we had another question. Joe, did you want to go for that? Miles has, I think, had a question in advance about the defunctioned rectum, I believe.
I don't know.
Mike, you are aware of this question. Just briefly for the audience, it's about the management of the defunctioned rectum and what should be our approach because of the risk of malignancy. So perhaps Mike, Mallory and Adolfo all could give us their view very briefly.
I think his question originated in somebody who had a history of colitis. Is that correct? So this is a slightly different scenario than we've been discussing now.
Sorry, Mike, I don't have the details of his question because he emailed it in, so I'm not entirely sure. But one would assume it's in colitis rather than.
So
cancer.
I think his question was in somebody who was, if I remember correctly, who was defunctioned for Crohn's disease, colitis, perianal Crohn's disease in 1999. Has come along. How does somebody survey that patient's colon? And I think the answer to that is with difficulty. And so in reality, if we take a starting point and a step back, my personal view is that defunctioning a colonic Crohn's or a colonic colitis isn't a very helpful maneuver therapeutically or otherwise. So I think you have to think very carefully about it. And one would beg the question, if this patient's still got a colon on since 1999, why hasn't consideration to removal of that colon to reduce that risk? You could CT scan the patient as an overview to look for a mass lesion, but then the time is too late because you've already got a cancer within that segment. Of course, all of this is prejudged by the risk in the patient, and that can be influenced. And there are good guidelines on this from NICE and BSG in terms of low risk, intermediate, high risk patients for colorectal cancer based on the severity of disease, things like PSC, family history, and you can stratify the patient. And I think if the patient was considered moderate to high risk, then we would have to be considering advising that patient they'd have to have their colon removed as a preventative thing in this situation, and just because there isn't a method of screening these patients, unless somebody could consider irrigating the colon and trying to colonoscopic that way, but I think that would be something that's unknown.
Thanks, Mike. Have we got time for one more question, Sunil?
Yeah, I think we've got a question on the MRI and endorectal ultrasound that's come in as well. So I guess maybe just briefly again from Mike and Adolfo about what you think might be useful or not with MRI and endorectal ultrasound. Maybe we can start with Adolfo. Adolfo, do you use endorectal ultrasound routinely in your rectal polyp management?
No, I think mainly used for cases where there's a suspicion of deep invasion, where mainly requested by the surgeons who deal with the polyps going deeper. And the rectal ultrasound is better than MRI, according to the evidence for T1 lesions, and the lesions are expected to go beyond there. MRI is more frequently or also requested in order to check the end status. But if we believe, but also there's overstaging with the technique. So probably same as we do for Barrett's neoplasia, if the lesion looks endoscopically removable and there are no clear signs of deep invasion, then en-bloc resection is a full biopsy technique which will guide us about the further stages. So for apparently superficial lesions, we don't use them.
Great, thank you, Mike.
I'm really sorry, but I didn't hear that. It just didn't come through. But very, very briefly, in exceptional hands, MRI scanning is very useful. But Gina Brown can tell you a T1 from a T2 lesion, but nobody else seems to do it with any degree of confidence. So as a general tool, MRI will literally tell us whether it's a cancer or not from a benign lesion at best, and we'll struggle even to differentiate between T1 and T2. Endorectal ultrasound scan is very user dependent. We've been very, very lucky to have an expert in the field in Cardiff until more recently. I know many units don't use endorectal ultrasound scan because they haven't had that expertise, but the evidence is if you've got someone with expertise, they can differentiate benign and malignant lesions. And personally, going back to the cancer margin, treating the patient effectively at the start rather than removing a polyp and then finding you've got cancer at the base or cancer within it, I think all of these modalities are extremely helpful, but I'm very aware that in the general populace, they're probably not available. So I think the reality is we have to use skillful endoscopists like yourself, Sunil, to be able to, and Adolfo, to look at these lesions. I think that's incredibly important. MRI to give us a bit of a gauge, and then to a certain extent, we have to accept there's a degree of compromise unless we can all train up and do endorectal ultrasound scan, because I think there is evidence in the right hands that it's very helpful, and I can share that for those who are interested.
Okay, that's great, thanks. I think we all probably agree that there is a lot of interoperator variability, and your comment about the right hands is actually very true in that. And who has the right hands is very difficult to often ascertain, because in general, all the published data on endorectal ultrasound seems to be very variable, but that's actually been great. I wonder if we can have just one last question, which for Mallory before we finish the session, because it's been such a great discussion. Mel, I just wondered, one of the things that seems to sway decision making is when you have a biopsy that says high-grade dysplasia. And there is a tendency for people to automatically assume that that is equal to cancer, whereas clearly that isn't the case. Any tips on how we might actually resolve that to a reasonable degree? Because clearly a lot of it is sampling error, could be, but I thought that the overall percentage of people who had cancer after an initial biopsy of high-grade dysplasia was no more than a third. Any thoughts around that?
Yeah, so obviously it is a difficult area, and the sampling is problem really, in that we will not make a diagnosis of invasive adenocarcinoma if we don't have submucosal sampling to make a definitive diagnosis. Please send us the endoscopy report. I've said that I think in my presentation, but say it again, because if we can correlate it with what you see and we know where you've biopsied from, at least that does help. And obviously it all has to be taken in the context of a kind of MDT decision making, so that, you know, we can only tell you what we can see under the microscope, but we always know that, you know, especially when access is a problem, that you may not be getting the best samples, and we may only have a kind of suspicion of malignancy. Suspicion of malignancy is pretty well correlated with adenocarcinoma. I think I very rarely see a case where we've said it is suspicious of invasive adenocarcinoma and we don't see that on a resection specimen.
Thank you, that's fantastic. That's been a really great discussion. I think we've got loads of questions, but we've run out of time for it. So just want to thank all the speakers for that. Thank you all very much. And we'll move on to, I think, a brief sponsor video before we move on to the next session. Thanks a lot. That was an excellent session, and our next speaker, who is going to deliver the state-of-the-art lecture on bariatric endoscopy, is a good friend, Dr. Rehan Hydari, who's consultant gastroenterologist and interventional endoscopist at University College Hospital, London. Rehan's one of the stellar endoscopists we have, who's at the cutting edge of this area of endoscopy and upper GI endoscopy. Many of you will be familiar with Rehan's work on Barrett's and the Barrett's registry, and I'm delighted that Rehan's able to join us today, and I hope you all enjoy the talk. Thank you.
Good morning, ladies and gentlemen. My name is Rehan Hydari. I'm a consultant gastroenterologist at UCH, and I shall be talking to you today about metabolic and bariatric endoscopy moving forward beyond 2020. So obesity is a global epidemic. All of you on this course will have encountered it in some shape or form. And in 1997, the World Health Organization put together an obesity task force. And the document said that obesity was a disease, specifically a complex, incompletely understood, serious and chronic disease, which was part of a cluster of non-communicable diseases that required prevention and management strategies, not just at an individual, but also at a societal level. Obesity is a worldwide issue. It's not just confined now to the developed world, but also the developing world, where health resources are often limited. And we estimate that 1.9 billion adults worldwide are overweight. And this is a chronic progressive condition that reduces our life expectancy. And we know that the life expectancy, once you have severe obesity, is reduced by up to a decade. It's also associated with multiple comorbidities, not just psychosocial, but also metabolic, such as type 2 diabetes, fatty liver disease, but also all of the mechanical issues around functionality and joint manifestations, as well as high blood pressure, dyslipidemia, leading to all of the issues around ischemic heart disease and coronary failure. Moving on from diabetes and setting the scene for my talk today is diabetes. And diabetes and metabolic diseases is now a global epidemic, not just affecting the Western world, but also the developing world, such as sub-Saharan Africa, but also the Far East. In the UK, for example, we know that over 3 million people are diagnosed with diabetes, and 10% of our total NHS budget is spent on the care of patients with type 2 diabetes. The morbidity, but also the mortality from this is not insignificant, and the estimated cost is up to £17 billion per annum towards the NHS on managing patients with type 2 diabetes. Another sequelae of metabolic disease is that of fatty liver, which has become more and more prevalent and is now becoming a global issue. And we know that the impact of this on healthcare is not insignificant, with 1 in 4 people having features of fatty liver disease, either biochemically or on radiology. And there is a significant overlap and coexistence of type 2 diabetes with fatty liver disease. And it is now widely considered that non-alcoholic steatohepatosis will lead to significant cirrhosis and the need for liver transplantation, overtaking that of viremic hepatitis and end-stage liver disease. Just focusing on metabolic diseases for a second, we know that this stems from insulin resistance brought on not just by lifestyle, but our westernized diet and also biology. And as the body becomes more and more resistant to insulin, we develop this insulin resistance syndrome, which will lead not just to metabolic diseases such as type 2 diabetes and fatty liver, but also infertility through polycystic ovary syndrome, and indirectly to vascular diseases and stiffening of coronary arteries, leading to ischemic heart disease, but also cerebrovascular disease. And we know that if we can reverse weight loss, if we can instigate weight loss, this will improve not just obesity, but also type 2 diabetes, hypertension, dyslipidemia, but also improve cardiovascular mortality and morbidity. How does the GI tract fit into all of this? Hippocrates said a very long time ago that all disease begins in the gut, and we know that there are multiple signals from the gastrointestinal tract that are involved in the homeostasis of glucose, from the duodenum with the expression of ghrelin and GLP, but also the jejunum, the terminal ileum, and also the colon and the stomach. And understanding the individual role of all of these areas will help us to intervene at different stages. And this has really come from bariatric surgery, which has illuminated the fact that the duodenum is critical in the role of glucose homeostasis. And we know this because when patients with obesity who have type 2 diabetes or metabolic diseases undergo Roux-en-Y bypass, and we bypass the duodenum, almost overnight their insulin resistance will improve, and there is clear evidence when you sample the duodenal mucosa that it is altered in response to high sugar in our diet, and this alteration leads to hormonal signaling, which leads to insulin resistance. So the duodenum is really key as a metabolic signaling center, not just physiologically, but also in the in recognizing westernized diet and signaling altered endocrine and exocrine function. And we know that if we exclude the duodenum, this signaling changes, and so if there's anything that we can do to alter the duodenum, we may be able to improve insulin resistance. So this is data that we published as part of the early work that we did with duodenal resurfacing, that we showed that if we took mice and we fed them high westernized diet, chow mice, for example, compared to mice that were on a normal diet compared to mice that were on a westernized diet, that actually the duodenal mucosal weight increased as well as the surface area by hyperplasia, and there was also an increase in chromographine A staining. So we hypothesized that high fat and sugar diets leads to duodenal mucosal hyperplasia and insulin resistance syndrome. So what can we do that can reverse this by targeting the duodenum? Well, we know this from bariatric surgery, which kicked off in the 1950s with bypass, and we showed that after surgery, not only did patients reduce weight, but their insulin resistance improved with a remission of up to 60% in type 2 diabetes, reduced cardiovascular events, and reversal of fatty liver disease, and also a reduction in mortality. And this has been shown in this seminal paper now some years ago from New England Journal, where 5 years on from the bariatric surgery, not only was weight loss improved, but so was the HbA1c in these patients, which was sustained and durable. So NICE recommends that those with type 2 diabetes who are obese should be offered bariatric intervention. But the problem is there's a massive unmet need, with less than 5% of these patients being offered sleeve gastrectomy or Roux-en-Y bypass. And we know that medical therapy, pharmaceutical therapy, has a limited intervention. So what can we offer these patients? And the things I'm going to feature on are duodenal manipulation for metabolic disease, but then also space reduction with endoscopic suturing. So how can we affect the duodenum? Well, there are different techniques that can look at small bowel manipulation or exclusion endoscopically. And these are non-device-based, such as duodenal mucosal resurfacing, which I have experience with, but then also device-based implantation procedures. I'm going to focus on mucosal resurfacing, and this was published last year in GI Endoscopy. Again, this was an early preclinical proof of concept study in rodent models, whereby using an abrasive brush to the duodenal mucosa in these patients, we lowered hyperglycemia in these rats. And again, when we looked at, after euthanizing these animals, we looked at the controls versus the post-duodenal ablation. You can see this partially regenerated duodenal mucosa. So the histology confirmed that this is safe, and a controlled thermal manipulation disruption of the duodenal mucosa could impact on glucose homeostasis. And this really paved the way for duodenal mucosal resurfacing. Now, this is a minimally invasive endoscopic technique. I did the first case about 5 years ago, and this is now being commercialized, and we're running the next wave of our clinical studies, having published the randomized control data, where we use an endoscope which is inserted through the mouth. This is then fluoroscopically a guide wire, a 0.325 Boston Dream wire, can be passed past the duodenal the jejunal flexure, the DJ flexure, the ligament of Treitz, and then a bespoke balloon is inflated alongside this wire, and this balloon has a unique property in that it is able to inject into the submucosa liberally to create a cushion, minimizing the risk of stenosis after thermal injury, but also mitigating any risk of transmural injury. And what is then done is hot water is circulated through the balloon, creating a thermoablative intervention, thereby disrupting the duodenal mucosa. And this procedure is started just distal to the ampulla, and sequentially we ablate 10 to 15 centimeters from the oral end to the anal end. And you can see this thermal ablation will disrupt the duodenal mucosa. Now, the device has evolved since I first started with a dual system where you have different catheters for lifting and then a different one for ablating, and we now have a combined catheter which has not only just significantly reduced the procedural time but also adaptability and reproducibility. So ladies and gentlemen, this is a short video just showing the procedure. You can see I've used an endoscopic clip here on the contralateral wall from the papilla, and using fluoroscopic guidance I'm then able to pinpoint where the papilla is, and then I can drop a wire distal to this far into the distal duodenum and past the DJ flexure. This is the balloon that is then passed with tension on the wire into the proximal duodenum, and you will see that the balloon has unique characteristics with these blue markers at the oral end. The balloon is then inflated to create the submucosal cushion. The balloon is 2 centimeters in length, and by a combination of gentle suctioning you can see how you have a generous submucosal lift, and then you apply this thermal ablation by circulating hot water for a minute, and you can see this white coagulant forms, and so on and so forth. You advance the balloon under fluoroscopic and direct endoscopic visualization to create this mucosal disruption, and that is the end result. So this was the first in human study, which was published some time ago in Diabetes Care. It was a single center study from Chile looking at the duodenal resurfacing procedure in a select cohort of patients with type 2 diabetes, where patients were scoped and following the intervention a mixed meal tolerance test was done at 1, 3, 6 and then 12 months. The baseline characteristics of these patients, they were all relatively young with A1Cs of 8.7% and higher. And just to remind you, this was not a weight loss intervention, but these patients by default had a BMI which was slightly above that that is recommended. And the headline here is that 12 months post a single intervention with duodenal resurfacing, the A1Cs were reduced by up to 1.4%, but also there was a reduction in fasting plasma glucose. You can see these graphs here. What is also quite interesting is that HOMA-IR, which is a marker of insulin resistance, was reduced, but unexpectedly we saw that the liver enzymes, the ALT and AST, were reduced as well. And this led to further analysis and further work, which showed that this was single DMR procedure after 6 months led to a significant reduction in hepatic transaminases compared to baseline. And you can see that in these two markers here. And then we went on to look at imaging using fibroscans, but also using MR hepatic fractions. We could show that there was a 30% lowering of relative fat fractions after a single mucosal resurfacing at 3 months. This was the second study, the REVITA-2 study again, and showed that DMR favorably impacted on not just metabolic parameters, but also MR signals, showing here on this image, you can see the reduction from baseline at 12 weeks in the MR representation of fatty liver. These data also show that this effect is durable. So when you look at the 12-month data, the A1C is the fasting plasma glucose, but also the HOMA-IR is reduced at 12 months, showing a durable response after a single intervention. The randomized control data, which was a sham controlled trial looking at its intervention at baseline and then a crossover at 3 months, showed that DMR positively impacts on glucose metabolism and metabolic signaling. And you can see here, ladies and gentlemen, that after compared to the sham procedure, the patients achieving an A1C of less than 7% was significantly higher. And this was at 24 weeks, also significant and also seen with the fasting plasma glucose. In the same randomized control sham trial, we showed that the reduction that we had seen in the initial human data in terms of liver indices, but also MRI fractions, was also seen in the DMR cohort compared to the sham cohort. And here is a graph showing the mean reduction in both ALT and AST. And this was seen to be sustained at 24 weeks. And so really paving the way for a minimally invasive endoscopic intervention for type 2 diabetes and fatty liver disease. Just for the final part of my talk, I'm going to go on to endoscopic bariatric therapies. And these are less invasive, potentially less cost impactful, can be done as an outpatient, can be reproduced, and can be used not just for cosmetic, but also for weight loss surgeries. And there is a treatment gap, ladies and gentlemen. We know that the difference between diet and exercise and medical therapy and surgical intervention, there is a large cohort of patients. So who are the patients that we can look at? Randomized data, the total body weight loss at 12 months is in the region of between 10 to 25%, but these all have to be removed. However, 3 years ago, there was an FDA alert due to the potential risks of balloon migration. And now we have procedure-less balloon, the ellipse balloon, which is swallowed on a string. And again, these show a total body weight reduction in the region of about 15%. But again, these do not show a durable effect. But there is early data to show that balloons can improve on comorbidities, in particular metabolic diseases such as type 2 diabetes and NASH. The procedure which I'm going to focus on now is the endoscopic sleeve gastroplasty, which is what I have a lot of experience with. And this is a minimally invasive endoscopic non-surgical procedure that reduces the volume of the stomach by up to 75% using a bespoke endoscopic suturing device made by Apollo. And the final shape of a stomach resembles that of a traditional surgical sleeve, but also without the need for incision and without the need to amputate and staple the greater curve. Who is the patient who is ideal for these? Women, but men also, younger patients, those with a BMI of 30 to 45, those with type 2 diabetes, with fatty liver disease, those who are not suitable for traditional surgery. So what are the data? The data here, this was published by Lopez Nava in Spain, who's had a huge amount of experience and shaped a lot of guidance on this, showing that at 24 months out, there was a total body weight loss of 18.6% in 248 consecutive patients treated with endoscopic sleeve gastroplasty. These data were published last year in an oral presentation at DDW and have now gone to press from the New York group, showing that this is sustained at 5 years, that you can see that at 5 years out, the percentage of patients in whom the total body weight remained at more than 10% was in the region of 70%, which is really, really exciting for a minimally invasive endoscopic procedure. But not only does ESG significantly reduce BMI, but it can also impact on metabolic complications in patients who are overweight, as evidenced here in these patients, where you can see that the A1Cs, but also the lipid and transaminase profile was improved significantly 12 months on from endoscopic sleeve gastroplasty. Not only that, but there is some evidence that physiologically and in terms of functionality of the stomach, this is reduced, and you can see these nuclear medicine studies and gastric scintigraphy show that there is a change in gastric emptyings of solids at 3 months out of the ESG. Compared to surgery, if we compare the length of stay, for example, it is a lot shorter. Now, obviously, the sustained weight loss from surgery is going to be far higher, but in select patients, this is highly effective. Finally, just to touch on aspiration therapy, this is now FDA approved, and really compelling data that the insertion of a large bore gastrostomy into the stomach, which can be aspirated, that at least 25% estimated weight loss at 52 weeks. So as repulsive as this sounds, the data are very, very compelling. Ladies and gentlemen, to summarize, intestinal mucosa is pathophysiologically implicated in insulin resistance and metabolic disease, in particular that in the proximal small bowel and duodenum. We know that manipulating this mucosa and selectively excluding it, for example, with the duodenal mucosal resurfacing, is now safe, effective, and durable in modifying metabolic diseases and insulin resistant states. And this is now evidenced by data from our sham-controlled trial showing that not only do we improve A1Cs, insulin resistance, but also liver enzymes. In conclusion, ladies and gentlemen, we have to be very careful as gastroenterologists and endoscopists, because bariatric and metabolic patients do not belong to us. We need to engage with our bariatric surgeons, with our endocrinologists and our diabetologists, and engage in an MDT format to make sure that we optimize their medical therapy, but also do not undertreat them if they need surgery. We know, as I've shown you, that fatty liver disease and type 2 diabetes and obesity have a significant health burden in the westernized, but also the developing world. And although surgery is going to be the gold standard for a significant cohort of patients, we can see that only a certain minority can access this. And minimally invasive treatments such as endoscopic sleeve and duodenal mucosal resurfacing show really satisfactory gains in terms of reversal of insulin resistance and weight loss, and will hopefully evolve over the coming years to become integral in the protocolized way in which we treat these patients. Many thanks for your attention.
Look out for, or if they face that situation, what would it be?
Thank you, Sunil. First of all, just a quick thanks to you and Joanna and everyone involved in organising this course. Thanks for having me involved. It's a real pleasure. That's a big question, actually. I think what I'd probably say is just be very careful. These are not our patients. You know, they belong to the bariatric and the metabolic MDTs, and so. But I think we need to be reticent to the fact that we are faced with these patients in our general clinics on a day-to-day basis. You know, those first few slides showed that obesity is here and is amongst us, and we need to be, you know, cognizant of the fact that people with an elevated BMI will be reducing their life expectancy, and although we focus on their GI symptoms, a lot of them will probably be derived from their obesity and their metabolic dysfunction. And intervening in those areas is just as important. So getting dietetics involved, looking at their fatty liver disease, looking at their type 2 diabetes, and plugging them into an obesity clinic early on, so that they can be around these people to then if in due course, if it's felt that lifestyle and medical therapy is not appropriate, that we can plug them into to some of these novel interventions, because only a fraction of patients are getting access to sleeves or bypass, or so we've still got a long way to go, and the data on these procedures will evolve. But it's an exciting time to be an endoscopist.
Indeed. Do you think that our training programs serve us well with this, or do you think this is something we really ought to incorporate into the curriculum?
Yeah, look, I think at the moment it's something that we've not embraced in terms of teaching. There is a little bit of a learning curve with endoscopic suturing, but I absolutely believe, in the same way that we've earmarked complex endoresection like ESD for streamlined training, that we need to, over the next couple of years, offer junior consultants, senior trainees the opportunity to learn not just how to do the procedure, but also the patient selection and the sort of metabolic and bariatric workup that comes with it. So, I'm hoping through the BSG guideline committee in the next year to have some guidelines on this and a position statement, which hopefully will then kickstart a bit of momentum towards getting people interested in an area that is going to be part of our daily practice for the next decade.
Fantastic. Thanks again, Rehan. Thanks ever so much. Delighted you could join us.
Absolute pleasure. Thank you for having me.
Cheers.
In treating mild to moderate ulcerative colitis with mesalazine, it is important to deliver mesalazine to the colon. Pentasa microgranules have an ethyl cellulose coating. The drug is delivered continuously throughout the gastrointestinal tract at all pH conditions. Pentasa tablets disintegrate into hundreds of microgranules, which can easily pass the pylorus and leave the stomach into the duodenum. Over time, the microgranules spread throughout the small and large bowel, releasing mesalazine. Pentasa microgranules provide continuous, diffusion-controlled release of mesalazine. Pentasa is designed to deliver most of the mesalazine dose to the colon, ensuring efficacy in ulcerative colitis, including left-sided disease. The anti-inflammatory action of mesalazine most likely depends on local contact with the diseased area of the intestinal mucosa. Pentasa was the first mesalazine formulation introduced with prolonged release microgranules. Pentasa has a wide range of once-daily formulations which may facilitate treatment adherence.
Thousands of people in the UK suffer from ulcerative colitis, a long-term condition that causes inflammation of the colon, as well as pain and discomfort. Cortiment is a medicine used to treat ulcerative colitis. It contains budesonide, a corticosteroid that works by reducing the inflammation of the colon caused by an acute attack of ulcerative colitis. Each tablet has a special coating that only dissolves once it has reached the lower bowel. Here, the tablet turns into a gel-like substance and releases the budesonide throughout the colon. Because the medicine works where it's needed, in the colon, there is less risk of unwanted effects elsewhere in the body.
One.
So, good morning again, everyone. I hope you've all enjoyed the morning session. I certainly have. It's been great to have some brilliant speakers and really good discussion. It's time now for the AGM, and I'd like to ask those who are not part of the Wage membership, so sponsors and people external to Wage, to please log out if you can and then log back in after lunch. We still plan to start back at 1 o'clock sharp and try and make up some time, but for others, please stay for the AGM. So just to begin with, this is also the end of my term as president, and it's been a really interesting couple of years. And a real privilege to be president of Wage and hopefully contribute a little bit to Wage becoming a more effective organization. It's also been interesting doing all this in the middle of a pandemic for nearly 40% of the term. And hopefully Wage has been of help to all colleagues in terms of developing guidance, recovery guidance for endoscopy, for GI services. And on that note, we will also be sending out some guidance from Welsh Government and the nosocomial transmission group very soon on testing for endoscopic procedures, which may be available more widely than it is at present. We've had some good meetings with Welsh Government on this, and hopefully the guidance will be disseminated imminently from the CMO, which is also one of the things I hope we have managed to achieve to quite an extent in these past couple of years, better engagement with Welsh Government and through what the National Endoscopy Programme is doing and our input into that. I've also been quite pleased at our engagement with the BSG, and despite, if it's not the pandemic, then previously the snow that scuppers our joint BSG Wage meetings, we've still managed to have very good engagement with the BSG. And the four nations remain very strong, and if anything, I think our representation at the BSG should be stronger moving forward, a fact that the BSG is cognizant of and actually really keen to help us achieve as well. We have had some very good applications for bursaries, and you'll hear more from our treasurer about that shortly. I hope that the educational meetings that we've had from Wage over these past couple of years have been something that the membership have actually enjoyed, because we've had some absolutely stellar speakers from around the world, brilliant talks and sessions, and it's really been a pleasure to be part of all that. I don't think we could have done all this without the great team I've had working with me, and I'd really like to thank Joe and Di and Haley and all other members of the exec, and Arvin particularly for doing our admin and keeping us on track for the fantastic job that they've done that's allowed us to actually move from strength to strength. So, and lastly but not the least, I'd like to thank all of you for your support in these last couple of years, which has been instrumental in us achieving whatever we have done. And so thank you all for that. So without further ado, I'll hand over to the incoming president, Hayley Hurd, for a few words. Thanks, Hayley.
Thanks, Sunil. Well, I have to say I'm quite surprised to find myself in this position. I didn't honestly expect many people to vote for me when Jared nominated me a couple of years ago, but I'm very pleased that they did, and I'm really hoping that I can make a valid contribution to the organisation. So I'm really looking forward to working with members and to do what I can to help strengthen the voice of gastroenterology and endoscopy in Wales, and to do whatever we can to support you to deliver the very best service for our patients. So I think WAGE is an excellent organisation with room to grow, and I'd be very interested to hear members' views on how the organisation could develop, and particularly on what we could do to help you. So really looking forward to the next 2 years and looking forward to working with everybody. Thank you.
Thanks, Hayley. Can we move to the Treasurer's report, Joe, please? Thanks.
Yeah, of course. Thank you. I'm going to share my screen. So I got a summary of our accounts. Oh, if I find it in a second. Sorry, wrong one. I hate it when people do this and they don't know what they're doing. Right. Can anybody see that? No?
Can just see your emails, Joe.
Oh, okay. What have I done now? I'm so sorry. I'm going to close everything else. No. I'm sorry. 2 minutes. Can you see this one? No.
No.
I'll try again. It's on my screen, but I don't know why it won't share with everybody else.
That's fine. You can read it out to them.
I am so sorry. Okay, so it would have been much easier to show you because it's all numbers, but it wants to share my emails rather than everything else. I do apologise. Essentially, from a financial point of view, we have a very healthy bank balance yet again. Despite the fact that we had the meeting cancelled, as we all know, in the spring, we've still managed to have a small net increase in our income from that. And we're very grateful for the sponsorship that we've been receiving from the sponsoring companies, and that has kept that increasing amount. Our bank balance is currently around 80,000. We've had discussions amongst us as an executive level about what to do with this ever increasing amount. And I think perhaps Sunil's already mentioned this, but something that we want to do is ask everybody's opinion really on how we should be spending this money. The meetings are expensive when we do hold them in real life, if you like, but because of the sponsorship, we've been managing to make small profit every meeting. We do have recurring costs every year, which are static, including our admin costs to Cardiff University for Arwen support, but that is essential. Sunil did mention that we provide a Training the Endoscopic Trainers course bursary every year. We had lots of applications for that this year, all excellent candidates. It was at very short notice, so we probably didn't give our applicants an opportunity to to fill out the criteria properly. But despite that, we gave away 3 full bursaries this year, and decided to support a further 3 candidates at 50%. This is something that we would again ask the membership really about how they feel about us supporting them on these similar bursaries in the future, and whether we should be providing more to quality candidates. Our membership numbers have actually decreased slightly this year. The memberships that we had as 91 full members and 54 associate members, which is a slight decrease from previous years. That's pretty much all I wanted to summarise. I'm really sorry I can't share my screen, but if anybody wants to see it, I'm more than happy to email it or share it in some other way.
Thanks, Joe. We can post it on the website for people to log in and have a look if they'd like to.
Yeah.
I think it's just before we move to the Secretary's announcement, I'd like to say that this issue of membership is really important. The only reason we've been able to have such high quality meetings is because of sponsorship. There seems to be a misconception amongst some colleagues that it is the membership fees that is keeping Wage afloat. It isn't actually. And it would be really good if people could show support for Wage through the very nominal amount that is charged for membership, because it would certainly help Wage to get better engagement and for members to see hopefully clearly the benefits of it. Yeah. So we'll just move on to the Secretary's announcement and
thank you, Cyril. So I'm just going to be announcing the result of the Vice President election. As people are probably aware, we had 2 excellent candidates this year in Dr. John Green and Dr. Tom Yap, and I'm extremely pleased to announce that the next Vice President for Wage for the forthcoming years will be Dr. John Green. So congratulations to you.
Thank you, Dai. I think all our congratulations to John, and we're very pleased that we have so many good colleagues who are taking an active part in Wage. I think we wanted to keep the AGM relatively brief from us so that we had a chance for members to ask us questions or comments or anything they wanted to, and still give people some time to break for lunch before we restart back on time. So very happy for people to ask us questions or any comments on whatever we've said. We will keep these channels open for the next few minutes, and please type in your sidebar so that our technical team can send those questions on to us.
There doesn't appear to be any burning questions.
Yeah, I think we maybe give it 5 minutes in case there is anything, and then we can probably break for lunch and join back just before 1. Have people found the meeting easy enough to join and audio, videos, etc. reasonably smooth, or have they had any technical problems? It'd be good to know that as well, because we're trying this for the first time. Okay, so we've got a comment from Miles saying the website needs more regular updating. Yes, I think we all agree with that, Miles. That's part of the plan, because we're trying to see if we move providers and try and get a more professional look to the website as well. Again, all of this depends on engagement with members, and members have to step up and become members first, because something we found constantly for the last few years is there are people who are voting who are not actually eligible to vote either. It would be nice to have, just as the colleges have and other professional societies have, a members login area, which Chin Lai, to his credit, did try and start off in the beginning, but hasn't quite caught on, and it'd be great if the new team would try and take that on, but it really is also for members to give us their ideas and input on what they'd like to see on the website, whether you'd like it to link it to certain guidelines and other things as a method of interaction or whatever else. So there's a question from Fires about when the next educational meeting is planned and are we going to have a meeting in spring? I think that's one I'm going to ask the next president to answer rather than.
Yeah, I'm not sure is the honest answer, but we did discuss this yesterday, and I think we agreed that we would have more conversations after this meeting and decide what to do. I think we would plan a spring meeting, but whether that would be a physical meeting or a virtual meeting, I think we're not sure yet. But we will discuss it and let you know as soon as we know.
Have we mentioned that we're planning on sending out a survey monkey at the end of this meeting for feedback? And we're going to discuss what questions to ask you, basically, but it would include what the membership feels about for the meetings.
Yeah.
Time for and format. But it does look like most societies are planning virtual meetings again for the spring rather than face to face, which is a shame. But if this works and everyone's happy with it, then
it's not quite the same. But I suppose we need to see what the land of the lie is.
So
we need to start planning.
We've got a couple of comments about the technical issues with the meeting, which some people seem to. I think I agree with them that Teams is not as good as Zoom. The only reason we actually went for Teams is purely because some health boards don't allow Zoom on NHS computers. Otherwise, I agree fully, Zoom has got much better functionality and quality than Teams does. I'm not at all a fan of Teams, but it was mainly done so that people could link in from work and still be able to participate in all this. It would be helpful if people could keep their comments, send our comments into Arwen and to us to let us know, because for next time we'll know whether we choose a different platform and test it out with NHS computers as well.
Yeah, and I think, Sunil, we obviously put this together at a very short notice, but I think as we attend more virtual conferences, we'll probably get to know the platforms a bit better and hopefully identify perhaps a smoother way of doing it for the next meeting, whenever that is.
Okay, I think there's a welcome to the new team and my thanks to everyone as well. Any other questions?
I promise I'll learn how to share content properly next time. Honestly,
I don't think it's you actually. Teams is a pain sometimes, so you have to unshare something and then share something else again, and it doesn't always pick the right thing.
I can try again, but I've still got it open. I'm going to try one more time. If anybody's
determined to show us that report.
But, you know.
I think while you're doing that, Joe, it's fair to say that we are quite exercised about the fact that we need to have processes in place for governance and for us to fulfill the purpose that Wage is there for. And we'd really like to do something in terms of education and training that helps our members. And the new team, I'm sure Haley will take views on that and decide what's the best way moving forward. But this fund is really to help members get to wherever Wage can help them with. And it's really important we have views from people about what would be a sensible and measured way that we can sustainably do that over the next few years. Any joy, Joe?
It doesn't appear to be. How is that? Is that working yet? No. I just want to cry. I don't know what I'm doing wrong.
It's not you, it's Teams.
There's a good example that we should not be using Teams in future.
Yeah, I think it's good that we've tested it out. It seems to have worked okay for a lot of the
everyone else apart from me, you mean?
None of the audience content for the speakers, etc. Hopefully people did manage to get a reasonably good quality of video and sound.
Should we let everyone have lunch now, Len?
Yeah, I think so. If that's okay, very happy for people to email in if there's any other comments. And we plan to start back right on time for the 1 o'clock session. So thank you, everyone.
Thank you. Bye.
Are we still